Okay. I'm on? Hey, all right, all right. So, and if I could get those slides up, that'd be great. Good morning, everybody. Welcome, welcome to the inaugural presentation, first webinar of PerfWeb, coming to you from our new The New Orleans Conference, Perfusion International, and HET Studios. It's a pleasure to have you all here. Appreciate you logging on and getting your CEUs. So through us, we appreciate it very much, and we hope that we are able to provide you a really good service. We've got a great program today, and in just a second, I'm going to have my slides up so that I know what I'm supposed to be saying here, because I don't have a reference point. But listen, I mean, and I'll explain this a little bit more as we move forward, but the concept here is that as perfusion professionals, we have some real problems in what we're seeing as the trend in decreasing reimbursements, not having CEUs in our budgets, practices where you don't have the ability to take time off, a one-man practice, two-man or woman practice, as the case may be, cost associated with traveling and the like. So what we're trying to accomplish here is to provide a convenient professional forum, convenient in time, for you to be able to come and get your CEUs. Here's some information that you're going to really need to have, which is your call in for questions and discussion. So you want to write this number down, and we're going to be showing this throughout the conference. It's 281-738-7906. So just on your regular telephone, call that number if you want to ask a question or you want to participate in the conversation. Please wait until we open the phones. We'll let you know when we're going to be receiving phone calls. Please be patient if the line is busy. You know, there may be somebody else who's talking. And keep in mind also that there's a 20 to 30 second delay but the call is live. So you're talking to us live, but what you hear on your end is a 20 or 30 second delay, and that's just something that you do with the web. It can't help that. So please turn your volume down on whatever device you're listening to the program on. Please try not to monopolize the conversation. You know, there's going to be times where you've got some important stuff to say, and we definitely want to hear it, but we can't have it go on too long, because we do want a lot of people to be able to call in and ask questions should they have any. Please try, and then your certificate will be emailed to you after the conference is over, to the email that you registered with. I want to say a few things about the New Orleans Conference this year. We are going to be back in New Orleans, and we would love to have you all come and join us there. It's going to be a great conference, as I think you know the New Orleans Conference is, and we're going to be honoring Dr. Tyrone David from up in Toronto as our Crystal Heart Award recipient. And of course, you know the New Orleans Conference is approved for CEUs and CMEs for perfusionists, physicians, nurses, mid-levels, PAs, NPs, and the like, everyone that would be involved in the heart care team. Our history lecture also is going to be chaired again this year by Dr. Trotter, which is fantastic. I'm really happy to have him back. And, you know, he's a great historian and lecturer. So please come to New Orleans, theneworleansconference.com. Why are we doing this? Well, difficulty getting to meetings. I kind of went over this already. Need for Category 1 CEUs, which, if you know the system within the ABCP, the SDCEs are only 10 maximum, where we need 45 total. And I think it's 15 have to be Category 1. We like to get all of them as Category 1. I think that's just more convenient for everybody. And this is going to give you the opportunity to be able to do that without having to travel to a meeting. Although in some ways that's hard for me, because I don't want to see people not coming to the New Orleans Conference. It's a fantastic conference and a great amount of fun. And we talked about all of that already. But something that's as much significant as all of that is that these webinars are frequently offered at the same time the conference is going on. If you can't take time off from work to go to a conference, how are you going to take time off to actually sit and watch the webinar? So we're doing these on Saturday mornings, Tuesday, Wednesday, Thursday evenings. Please check our website, perfweb.us. That's perfweb.us, and that'll give you our schedule for the upcoming webinars. We want quality presentations. We've got a terrific faculty. We're going to be doing a lot of discussion-based stuff and interactivity so you can call and be involved. We're using very advanced technology. This studio was built for this purpose, almost this purpose alone. This table that I'm sitting at here was actually hand-built by the father and brother of our director of multimedia operations, who are fine furniture craftsmen from Mexico, and it's a beautiful table. Would love to have you here in our audience if you'd like to come and actually visit us live. It's also an opportunity for perfusionists who may have some great content and great lectures that they would like to share with people, that we can bring you in remotely via Skype, WebEx, GoToMeeting, or whatever format you like to use. We can use all of those as well, and you can actually be one of our lecturers. We'd also love for you to come here and actually sit at the desk and be a part of give a lecture and be a part of our discussion groups. We think this is going to improve learning compliance and ultimately help to provide better care for our patients, because at the end of the day, that's what it is really all about. It is free to watch. So we want to open this up. We think the sharing of information is extremely important, and disseminating information to our colleagues shouldn't always come at a cost, but if you need the CEU certificate, then we do charge for that. So please be aware that you can watch these even if you are not actually needing the CEUs, but you just want to learn, which of course makes me feel really good. And we want you to participate. So that's my last slide. I want to move right forward with, again, welcoming you here. And I want to bring up our first lecturer, Dr. Zsolt Garami from the DeBakey Heart and Vascular Institute, to talk about TCD. Dr. Garami. Good morning. It's good to see you.
Good morning, Joe. Nice to see you too.
And we might be working out some kinks, so if things run a little bit slow on our first one, we have to obviously get through any kinks. So be patient with us, okay? We appreciate that also very much. And
so while we are waiting for a first slide, I just want to thank you for the invitation, and it's a pleasure that I'm the first one who can.
You're our first speaker. You're our first faculty on a Saturday morning at 7:30.
Yes, I'm so glad that you guys don't see the outside weather, because it's a really welcoming weather here in Magnolia.
Yes, very foggy.
And yes, and I really wanted to cut the ribbon, so I think that we missed that opportunity.
No, the ribbon cutting ceremony is at lunch.
Lunch. Oh,
yes,
okay.
yes,
Very
yes.
good, because I really wanted to bring my scissors.
I understand that. So, Dr. Garami is going to be talking about TCD, and, I have to say this as a disclaimer if I can. Years ago, Bob Groom was a strong advocate for the use of TCD, and frankly, I thought it was just a bunch of hogwash and was sort of, really not too keen on the idea. But as I've gotten a little older and a little more experienced and gone through some things and seeing patients who have suffered stroke during the cases that I've done post-operatively, I really think I was wrong. And Bob, if you're watching, I apologize, because you were right all this time, and certainly history has borne that out.
Well, thank you, and we would like to really tailor this talk as a TCD Basics for Perfusionists, my disclosures, I definitely have some teaching consultation agreement with few companies, and because we are from Houston, I just want to show you when astronaut Kelly came back to Houston, We don't waste time, so we do a cardiac, carotid, and orbital ultrasound at the same time. So I think my love to ultrasound is definitely the priceless disclosure. And on the right, you can see a stunning image, what the ultrasound can show you. So this is not a CT scan. This is a frontal lobe transcranial Doppler image of a brain. So the first TCD was built by Dr. Elsley in '82. So this is not a new technique. And when the first TCD was built, it was a single channel TCD. This is on the this image right there. And about 2000, Mark Moring gave us an M mode image. The M mode image is that red ribbon that what you see as a first screen on the top of the spectrum. And that red ribbon is really gives us the GPS for the entire hemisphere. So it's so much easier to find the signal because you have like GPS coordinates where the blood vessels are. So that makes our life so much easier to find the signal. And I think the underutilization of the TCD is really coming from the lack of training and lack of understanding how does this blood flow really looks like on our ultrasound image. So the ultrasound image, what I'm going to show you today is it looks like this, and this is the first publication that on the upper side you see the red signal when the ultrasound coming, the signal coming towards your probe, and these ultrasound signals basically reflects from the red blood cells. So the red blood cells, nice flat surface, give you a nice unique signature, and this is how we can measure the speed of the red blood cells. So we measure it in centimeter per second. That's on the bottom screen. And the centimeter per second speed measurement is actually almost similar to miles per hour. So a normal person, how you drive on a highway when it says 60, so that's kind of normal speed for our brain. The mean flow velocity we calculated from systole and diastole, and we have the expected range of mean flow velocity between 20 and 80. If a mean flow velocity is your speed limit goes above 80, we think there's a narrowing in a blood vessel. That's what brings this speed up. Or if you have a blockage, then when we go slower than 20, seem like a traffic jam on the highway. The ACA is a blue signal because of the speed and the vessel flow is directed away from your probe. This is why your flow is blue, giving you a different direction. And I think the interpretation of these signals are depth, direction, and the resistance. Those are the key elements of how we can describe these TCD signals and screens. So this is just one more example that how a TCD screen look like. And what you see here on the right-hand side is the speed information. On the left-hand side, it shows you the depth of the signal was calculated, and the signal is represented by this yellow line. So that's the depth of the yellow line where the speed curves are received and calculated. And one more important information about TCD, what I think is differentiating from EEG, that it's really objective. So those numbers are real. So on the top of the velocities, we also have a PI values that tells you how much the vessel is open or how much resistance works the blood flow against. So these PI values are normal between 0.6 and 1.1. You can see it on the bottom of the screen. That's your normal. If the resistance is really minimal, for example, an AVM, this is when you have almost non-pulsatile waveform, or when you have like a non-pulsatile waveform, when you're going to see some examples on the pumps. When your PI are increased, the PIs will be like a chronic hypertension, increased ICP, going to shut down your diastolic perfusion. That's very important that we can again describe where obstruction happens. So during the case, if we monitor, we can pick up those occluded vessels without waking the patients up. And I think that's the advantage of TCD.
Mm-hmm. So can I just throw this out? So when they pick the heart up and they restrict the drainage from the superior vena cava, when they're really torquing it over to get to an OM graft or something like that, and our flow goes down, we're struggling for volume, and we're assuming, of course, I think reasonably, that the head is getting congested. Would you see that on that flow probe?
Exactly, and I think the TCD, I would call it almost like your centralized blood pressure read, because the brain is probably attracting about 25% of your total cardiac output. So if your cardiac output is down, definitely the TCD signal is going to show that. And forgot to show you, I just want to go back to the slide, that this delta percentage change on the bottom, if I push that for 100%, that would be my established baseline. At the beginning of surgery, even before anesthesia would start, the general anesthesia, that would be my 100% baseline, which would be the relative number that I don't need to remember what was my mean flow velocity. I'm just looking at, and I do not want to exceed about 20% flow changes. So 20% is what we can, again, communicate clearly that I have 20% drop, and that kind of alerting the anesthesia as well as the surgeons that we have a flow change. Quickly, I just want to show you that, and exactly similar, how do you see this blood flow change? Watch, I'm just going to put my fingers on the carotid. This is how the flow changes immediately. So why on EEG you're waiting 2 minutes to see some changes. Here, the flow changes are immediate in milliseconds. So this is the normal flow pattern, and when I put the finger on the carotid, watch, immediately shows you there's a blockage. That blockage flow change tells you there's something between your measurement point and the heart which is blocking your flow. This systolic upstroke on the TCD waveform, that systolic upstroke assures us that the between your measurement point and the heart, definitely there's no blockage. And I think that's a pretty cool basic information what we're getting. And this is the other information I wanted to show you and kind of make it nice and clear to understand this blood flow pattern inside the middle cerebral artery and the ACA. Again, just one more time, this is the 2 carotid coming up, and this is the 2 MCAs with the 2 red and 2 blue signals. Let's block the carotid. And in the moment you block the carotid, you're going to have a reverse flow coming from the other side, and this is how you can reverse the flow in the ACA. And now, even if you're colorblind, you can probably see that the waveform is switched from negative to the positive on the spectrum. So you see that the blue signal represented a negative value, while the red signal is a positive value. So you can see it's crossing, then changing direction if it's needed. So I think those are the flow direction changes that we can quickly see. And this is, for example, if you're cannulating just the axillary artery, you expect to see bilateral MCA flow. But if your circle of Willis is not intact, you're not going to have, with single cannulation site, bilateral flow signals. So this is where the bilateral flow signals are must have, and this is why we are trying to teach our audience, because even in the vascular ultrasound schools, TCD is probably underutilized. There was a questionnaire by the Society of Vascular Ultrasound and Credentialing Societies about the 1,000 vascular labs running in ultrasound and answer the questions. Only 10% of them they even use for TCD as a diagnostic purpose. And even from the 10%, I would say the number of hospitals that are using TCD for intraoperative monitoring is even less. And definitely you and me, if I want to have any kind of surgery, my first question would be, who is the anesthesiologist, not just the surgeon, who is the surgeon, but I think it's very important as a team approach that someone is also looking after your end organ. I think the brain, you can fix my heart, but if my brain is blown and I have a stroke, I really don't care too much how successful was the surgery.
That's, and on type 1 dissections with deep hypothermial circulatory arrest, and you're talking about antegrade versus, of course you didn't mention it, but retrograde. So if you don't have an intact circle of Willis and you've only cannulated unilaterally and you're flowing along, you won't know until after the procedure whether or not you actually perfused the contralateral hemisphere of the brain.
And this is the slide kind of teaching exactly the same point, that this is just the study of how many collaterals are missing. So let's say that about 50% of the people, they do not have a complete circle of Willis.
Wow.
That 50% is really a scary number, but And sometimes we really cannot determine just by MR. So we're not going to do MR just to learn if you have a cervical villus or not. But in a stroke patient, when we study this, you can see that it's also predicting how good is your survival chances after the stroke. So if you have anterior communicator, posterior communicator, and even your ophthalmic helping out, all the three major collaterals working, you have a pretty good chance with all those collaterals you can survive a main carotid occlusion and stroke. But if you do not have those collaterals, almost your chances are 50% to even survive your first year after the stroke. So I think these are really scary numbers, and these are the numbers are also associated that not when you're looking at the extracranial stenosis, and we do screen for carotid disease before we go to the cardiothoracic surgeries, the carotid ultrasound screening is just not enough, because the carotid is here, the carotid doesn't end up here. The carotid really hooks to the middle cerebral artery behind your eyes. So we are investigating only the extracranial part, and sometimes based on extracranial flow, we can predict maybe there is some disease distal, but I think to really look at the carotid ultrasound needs to be really combined with a transcranial Doppler to really see what is the blood flow doing in the brain. So the carotid is definitely not enough to investigate the blood flow in the brain for sure. And the TCD, again, is not a investigational device. These are the billing codes associated with a TCD, and this is, I think, since 2005. So this is not like last year. Definitely, I don't want to comment on those reimbursement and how does it change, but definitely each state has a different reimbursement rules. I can tell you that the TCD reimbursement is still better than a carotid, for example, probably for the reason that it's not as well utilized, but also not available everywhere. So I think they are awarding those people who are doing TCDs, and these are the billing codes that we do the regular diagnostic, the 86. But also, I think it's very important that I believe the TCD with the PFO testing probably can beat even the TEE to detect those PFOs or ASDs. The reason is real simple. So when you have an echo image of a 2D view of the heart, it's a cross-section. The bubbles can go on the front of that screen or behind the screen. You really need those bubbles to be able to cross and see those few bright spots on your echo. What we monitor with the TCD is the entire 3D flow pattern, and even a single bubble is enough to pick up in the brain. Bilateral or unilateral, doesn't matter, but we see these testing are done in a sitting position, so your Valsalva maneuver definitely has a better effect on you, and we do not have to sedate. So I think without sedation, definitely you can perform better Valsalva, and I think that also triggers a better response for us. The other important part is this breath holding index. When the breath holding index is with a simple 20-30 seconds interrupt your breathing, able to tell us how educated and how well trained your vessels. So the vessels needs to react immediately for lack of oxygen or the CO2 increase, and with that diameter change, the vasomotor reactivity can be tested. And our last, the emboli detection, I'm going to show you some example for emboli detection. First, this is the breath holding index. It's a real simple calculation. We try to monitor it on both sides at the same time. So with the same CO2 or hypoxia effect, we'll have the same effect, and you compare the two sides. And this is how the position the sonographer for the diagnostic TCD. We're sitting at the bedside at the patient head, and we start with ophthalmic, then we go to the transtemporal window, and finally the transoccipital window. And through this diagnostic test, this is the different signals we can use for the purpose of monitoring in the operating room or even in the in our office. We do utilize a head frame, and later on I'm going to show you the head frame. This is just one more image for the submandibular ICA, that if you don't have temporal bone windows, we can definitely utilize the submandibular ICA, and also we use the submandibular ICA for the subarachnoid hemorrhage patients, because that's how we can compare the flow, the intracranial and the extracranial pattern. And My boss, Dr. Lumsden, definitely a believer of transcranial Doppler monitoring, and we do all his cases under TCD monitoring, all the carotids, all the TVARs, and he believes definitely TCD is the best method for all the cardiovascular and cerebrovascular monitoring during the surgery.
Now, for the heart, now that's for his vascular surgery and carotids. At Houston Methodist, you guys are using TCD on all of your open heart surgeries as well.
Just yesterday, we had a type A, and it was affecting the brachiocephalic flow, so it was a stunning differences again between right and left. And I think those are the really easy confirmation that if you really fix the flap and that dissection is fixed, you will see the improvement of the flow right away. Or let's say that the dissection is progressing and the left side was not affected, but during the surgery something happens that you see that dissection progression too. So I think it's stunning that a live monitoring of the blood flow tell us if the origin of those carotids are affected. We do provide monitoring all our the TAVR cases. So the TAVR is more challenging because we started with a patient population average age of 85, 80. And especially the ladies, it's not a sexist comment, but suddenly we noticed that it's really hard to get through the ladies' skull. Probably the osteoporotic air pockets are blocking our ultrasound to get through the bone. This is why we came up with a solution that the submandibular ICAs, it's a good solution to really look and monitor those cases if you can get the signal through the transtemporal bone. And this is how a microembolus signal looks like. See that red dot in the middle of this waveform. So it means that the ultrasound signal reflected in the background from all the red blood cells. And it's just one single piece of embolic signal just reflected. It means there's something else traveling between those flat red blood cells. That could be a spheric air bubbles, there could be an irregular surface clot. We can't tell you what it is, but it tells me that it's something there we're not supposed to. So I think very important if you do a surgery, and yesterday we did a TCAR case also, that we're able to deploy a stent in a carotid without embolization.
Wow.
That's a winner for the technology and also a winner for us, that we are protecting the brain and able to do procedures with zero embolization. It means, hopefully, zero complication.
It's a winner for the patient.
And I think that zero complication should be our goal. So I think we shouldn't have something like, hey, 1% complication is acceptable. Mm-hmm. For me and for my brain and your brain, I would say 0%.
0%.
So, and I think we have that goal to really improve our new technology and investigate how we can make it better. And this is just one more example of how the embolus look like. And this is running in the middle cerebral artery, the red signal. The blue signal is in the AC, and this is how we're able to see them. And this is just for fun to probably conclude our first TCD session, is because we are in Texas. So this is how damn easy to differentiate a cow here in Magnolia from a dolphin. If I see a dolphin, just not in the picture. So definitely an embolus needs to be moving together with the bloodstream. If the signal is sitting on a zero line, it means zero speed. So unlikely you get a speeding ticket for not driving. So you must have a driving and you must have a speed for your embolus signal. So the first signal, this is an example of the embolus signal, needs to be in the bloodstream. If something is sitting on a zero line, it doesn't go anywhere. So these are the examples, and you can see it doesn't give you a moving signal here on the M mode. It's just deleted because you are just having a jaw movement muscle or just stepping on a probe. Sometimes a blinking eye able to generate those signals.
And is there an angular component to it as well?
So the angulation is probably, you can see it on the embolus if you see that the proximal MCA, why it's traveling to distalis takes time. So this is the distance from 60 millimeters to 30 millimeters. So that's only 3 centimeter trip. So this is not a trip to the moon, but it's just a trip to your cortex. While you're traveling that 3 centimeter, you definitely have like a forward slash kind of pattern that it takes time to get the 3 centimeters. And you can tell what is the speed, because the speed is here red on the right side of the screen. So it says 40. Sorry, you see underneath the tapping words?
Yes.
And this is where you can see that this is the scale for the speed. It's okay.
That died.
So that's my first part of introduction of what you see on the TCD screen, and with my second, yeah, it's moving again. So with my second lecture, I will return and going to show you more live cases, how we can utilize TCD technology in operating room.
I'm looking forward to that. So
thank you so much.
You're welcome. Thank you. I'm going to be, how about if we have a word from our sponsors, and we'll be right back for my presentation on stroke.
Optiflow arterial cannulae, less jet, more natural dispersion. Neurologic complications during on-pump cardiovascular surgery are often induced by mobilization of atherosclerotic plaques, linked to enhanced wall shear stress of the arterial cannula jet flow. Optiflow arterial cannula features a unique basket tip with large openings that allow a more physiological flow. Optiflow arterial cannula has shown to reduce the pressure on the inlet jet system on the aorta, thus mitigating arterial embolization of atherosclerotic plaques. After purse strings have been positioned and the incision in the ascending aorta has been made, Optiflow arterial cannula is inserted, then turned towards the aortic arch to allow a centralized flow. Optiflow provides optimal dispersion flow with no jetting compared to a standard tip cannula. The dispersion flow of Optiflow reduces the wall shear stress values by approximately 50% compared to a standard cannula, with the potential of reducing ECC complications such as strokes, endothelial damage, and hemolysis. Optiflow arterial cannulae are available with straight and bent tips in 21 and 24 French sizes for all patient needs. The unique basket tip design reduces the pressure gradient along the cannula, thus improving blood flow dynamics. Tubing is DEHP-free for a clear and more transparent look and feel, available with and without wire reinforcement.
Okay, well, welcome back, everybody. How are you? I'll give my talk on what do we perfuse is the title of it, but it's really about stroke. And as I said earlier, you know, Bob Groom really deserves a lot of credit for bringing this to light some years ago, certainly more than 10 years ago, and maybe even more than that. And it wasn't until I really met Dr. Garami that I recognized how much Bob had actually contributed to the concept of monitoring the brain, which is really a critical organ for us to be perfusing. I mean, as a perfusionist, what are we perfusing? Well, you know, certainly the body as a whole, and certainly the limbs, and certainly the heart, and the kidneys, you know, we use cardioplegia, the liver, and the gut, and all of those things. But at the end of the day, you gotta protect the brain. And we do a terrible job, I think, really, at focusing on this. We assume a lot. I think this picture for me says a lot. There's 100 billion stars in the Milky Way and 100 billion neurons in the human brain with over 100 trillion synapses. That's staggering numbers, really. And how do we measure the adequacy of perfusion? Well, we assume a whole lot. We do some fancy calculations. We monitor the SVO2. We do labs and look at the acid-base balance. We might even calculate the DO2, and we even use cerebral oximetry. But cerebral oximetry is kind of a tricky thing. You know, I think we've been lulled into a sense of security with this technology. The concepts are easy, but making them work in a usable device is really very, very hard. The big problem with these devices is figuring out the saturation information coming from the skin, the subcutaneous tissue, the muscle, the bone, and the brain, and venous versus arterial blood. And being able to differentiate from all of that for any technology is really quite complex. And I would argue, and I'm going to show you a slide moving forward, I would argue probably not very reliable. Each of these devices of cerebral oximetry, and we know there's several on the market, uses a different approach for delivering light and analyzing the light being reflected back. Each device uses a different approach to compensate for adsorption by the different tissues. The analysis algorithm for every device is different from every other. No two commercial oximeters measure the same thing. The specific algorithm used is secret, and the companies keep changing their algorithms and technology, so a study in 2005 may not actually be applicable in 2013. The algorithm in 2013, more than likely not applicable today. No device is capable to provide a pure brain O2 saturation, no matter what the promotional literature may say. The signal from the devices is contaminated by a tremendous amount of extracerebral blood. And this is the slide that I think says it all. The cerebral oximetry readings there on the left is of a live patient. Now, if we were to kill the patient, well, we are still going to actually get, or could get, and frequently get, a brain O2 saturation with the patient deceased. But it gets even better than that. If the patient is deceased, and hopefully we would do this after they were deceased, and we simply removed their brain, we will still get a reading. And yes, a lot of people say an awful lot with very small or lacking any brain at all. Well, in stroke, there is no good stroke or small stroke or anything else. A stroke is a stroke, and it's bad. Perioperative stroke rates in cardiac surgery range from 1.7 to 2.9, but encephalopathy rates, which we're going to talk a little bit more about, are 7.7 to 13.8%, with frequently harder to diagnose. So you get the patient who comes in, they have a stroke, they have a hemiparesis, they're unable to speak, their face is drooped. It's obvious they had a stroke. But there's a lot of strokes that are simply not seen because they're not gross. But the family says, Uncle Joe is just simply not the same person. They're more forgetful. Their personality has changed. Their attitudes have changed. And these are these subtle changes that you see. And frequently these patients can become very combative in the ICU, delaying extubation and also delaying transfer out of the ICU, increasing costs at the end of the day. So let me take a quick break here and beat on myself and some of my perfusion colleagues. Do we, as a routine, have any idea what happened to the case unless we get called and it's a callback for bleeding or whatever it might be, or we're putting the patient on ECMO in the ICU? Generally speaking, do we go and check on these patients in the ICU? Do we ever see the patient postoperatively, or preoperatively, and assess these patients before they actually roll into the operating room, which is really more than likely the first time we ever have any exposure to the patient? And do we see the patient post-op at any time, in the ICU, on the floor, at discharge, or are involved in any way beyond the procedure that we did? So how do we know we did a really good job on this patient and they're the same patient they were before we got them? Well, the answer is no. Or infrequently. I'm not going to say no entirely, because I do think that there are some who are more heavily involved. Of course, you know, there's considerations in terms of how much time we have, how many cases they're doing, staffing levels, and so forth. I do understand all of that. But irrespective of that, I think that at least some level of following this patient postoperatively may be something that we as a profession may want to consider to be more a part of our responsibilities. I think it would teach us a lot. Strokes are deadly. There's a threefold increase in mortality at the end of 10 years. They're debilitating. For many, especially the elderly, it's worse than dying. They would rather die during the operation than wake up having had a stroke. They can't maintain their independence. They can't enjoy normal activities. Their quality of life is severely compromised. They have decreased cognition and mental ability. And it is incredibly financially devastating for the patient, for the hospital, and for a society as well. So there was a whole point of time in our history where the pump was bashed. It was all about the pump. The Wall Street Journal circa 1990 blamed the pump for cognitive dysfunction. It was considered pump head, if you all remember that, those of us old enough to remember that. Dr. Stump, of course, did a lot of work on SCADs. Of course, we were transitioning from bubble oxygenators to membrane oxygenators, and of course, that made a big difference as well. Off-pump cabbage craze came into vogue predominantly over this concept of pump head. And there's another article here of off-pump versus on-pump coronary. The coronary study, I love the way they do that. The coronary study is coronary, off-pump, on-pump, and something else. It's the acronyms really are pretty good. But this was 4,700 plus patients from 79 sites in 19 countries. And what they found, if you take a look at this slide here, is that really on the primary endpoints, that what was the real problem, and I can't get this to work, but if you look at stroke was a little bit worse on pump, oh, thank you very much, Zsolt, on pump than off pump. But death rates were the same. Non-fatal MI was a little bit worse. New renal failure was actually worse in the off pump group. But when you look at the Syntax trial, for example, you know, they talk about, when the cardiologist goes and talks to the patient, they say, look, you know, your stroke probability in this operation is going to be this. If we do this stent, it's going to be less. Or the surgeon says, if I do it off pump, I'm going to have a slightly lower stroke rate than if I do it on pump. So, you know, those are the kinds of things that I think really matter. And how much of this stroke is really related to the pump? How much of it's related to flow if you are on bypass? How much of it really is embolic events? We know the cross clamp creates a problem. The Embelex catheter used to be in existence. Of course, it's been removed from the market. Sadly, it was a great device, but that was a political problem with Edwards and the FDA, and I think that really needs to come back. But the coronary study concluded that at 30 days there was no difference in the primary outcome between off-pump cabbage and on-pump cabbage. Off-pump cabbage was associated with less transfusions and reoperation for bleeding, less acute kidney injury, less respiratory infections and failure, and more early revascularization. So that's very important. So if you had an off-pump cabbage versus an on-pump cabbage, then your grafts were more likely to close than if you had the operation with a still, quiet heart. So it really isn't the pump. Is this too early for this morning? I don't know if it is or not, but that's basically how I feel about this whole argument of off pump and on pump. I think you do a much better operation on pump than you do off pump. At least that's how I would want my coronaries done, and hopefully I won't need coronary surgery. At least I'm hoping that. But I would rather have it on pump. But I think that if I had it, I would like it to be with TCD. So something that has really brought stroke to the forefront and what we're thinking about it in terms of the cardiac surgery world, whether it be coronaries or valves or anything else, is actually TAVR. So it has opened our eyes, and a stroke occurs in TAVR nearly 100% of the time, and I'll explain that. Majority are embolic, and all strokes, whether they be gross frank strokes or whether they be these subtle changes that occur, are consequential. And it has launched a new industry in cerebral embolic protection devices. So let's talk about that 100% stroke rate. Here's a diffusion-weighted MRI of a brain, and you see the white lesions in there. The arrows are pointing at it, and also on the right. And these are embolic events. These are new lesions on diffusion-weighted MRI. So the new stroke classification says that you have to have, for a new device, a new TAVR valve coming out, for example, you have to have a pre-op and a post-procedure diffusion-weighted MRI, and you check to see if there are any new lesions. If there are, then it is considered a class 2 stroke. So class 1 stroke, what we're all used to seeing, you've got a major problem or worse, and in a class 2 stroke. So with TAVR procedures, and I'll say it again, 100% of those patients are having strokes. Now, with that said, we don't know what's happening on pump. We don't know what's happening with just heart surgery in general, manipulating the aorta, clamping the aorta. But I would suppose if we did diffusion-weighted MRI on patients who have heart surgery, they too would have new lesions, and it's probably pretty close to 100% of the time, I would think.
Well, this is a great proposed study. We definitely do not have DWI after CABs, and I think the previous publication was the 4,000 numbers were really impressive. I remember
the coronary study?
Yeah, because I remember publications, just 20 patients in the same group, and in those cases when we studied with TCD or DWI, we saw immediately a embolization difference, but at the 6-month outcome, there was no difference. So even if you're looking for these subclinical DWI lesions or cognitive changes, I think we still need to define and we need to better tune even our cognitive function changes. Mm-hmm. So these subclinical stroke, what the DWI picks up, it's maybe not subclinical at all because they are accumulating. We do not have the clinical effect right now, but maybe 3 months down the road when the patient don't remember the name, those are the changes results of these DWI lesions. Mm-hmm. Not at that moment, but maybe down the road further.
Now these are embolic lesions.
Yes, but these white dot means that those are dead neurons. Dead neurons with free fluid outside. Means that the cells, they release their contents. Mm-hmm. That content is never going to come back. Sometimes we talk about diffusion changes which are irreversible and reversible. Sure, reversible, but it means that they are gone. So I think it's very important that these white lesions are only positive up to 7 days. Mm-hmm. So if you had a procedure done and you do a DWI 10 days later, you're not going to see anything. Mm. So you really want to do the DWI MRI as closest to the procedure as possible. So you also have the DWI lesions related to that procedure. Mm-hmm. So you don't want to do it 5 days after the procedure because you don't know what happened the postoperative 5 days. Those postoperative 5 days blood pressure changes, anything can relate and result on those DWI lesions. So I think it's very important that within few hours after the procedure, we need to see these DWI lesions.
And that's difficult. That's difficult to do when you are, you know, in the ICU. Maybe they do an early extubation. Maybe they're still on the ventilator. It's going to be very difficult to do this for CABG patients. But I do think that we don't. Really, at the end of the day, we just simply don't know, and that's, I think, one of the biggest problems that we have. So I want to show you this video and kind of explain a little something to you, how marketing works. You see the catheter going up. This is a TAVR procedure, and you see the balloon right there. And I want you to take note. Look at how beautiful, almost right in the central lumen, that catheter goes up. Now here comes the device, and it goes up the vessel, and they just going to deploy it now. Here it comes. Watch it come up and go around the arch. I want you to watch this. This is why 100% of TAVR patients have strokes. So this is what the marketing shows you. This is what the public sees. And there it is right there. Okay, now we're deployed the device. And there we go. We're rapid pacing. Now the valve has been deployed. And the heart's beating again normally. And they extract the device catheter, there you go, and the wire comes out. Did you see how pretty that was? I'm not going to show it again, but if you want to go back and reverse it and see it, you can. But this is a reality of what you see. In picture A, you see that same catheter coming around. So when those wires go up, they tend to ride up high, and that catheter is a pretty good sized catheter. What's that? It's a 20 French, right? 20 French or 22? It's
I think
really
we started
big.
24,
maybe
but right now it's 18 now.
18 French. It's still pretty big.
Yeah.
And that has to make that curve around the arch, and it scrapes the wall. And as it scrapes the wall, it knocks off calcium, atheroma, and anything else that might be there. And then it goes in, and then you deploy it or inflate the balloon or whatever the case may be that you're doing. And of course, there's calcium on the valve that's going to get broken off and go flying upstream. And then there you see the device with some residual. And this is what the cerebral embolic protection devices look like. So it gets deployed in the innominate and comes down, and then you block the innominate and you block the left carotid. The left subclavian, we're not worried about their fingers. And this is something I think you're going to see more of in cerebral embolic protection devices. It'll be interesting to see if it becomes a standard of care for routine procedures.
Well, I think we still need to study this because interesting trials and FDA approved definitely, for example, this Carotid device. It's important that these treatment and control arms, they have similar lesions. So until you really don't see the huge improvement of that, you are protecting the brain, you have less DWI lesions, you have less embolization material picked up by the TCD, we shouldn't be happy. So I think we started to care about protection, but I think these devices are still not the perfect devices. Definitely while you placing these protections, you have unprotected period, exactly. So you do have unprotected times, and when you're retrieving it, you're closing that filter up, you're definitely going to squeeze out a few of those embolic material right there. So I think these deployment versus collecting those debris needs to be probably improved a little bit.
Yeah, that's really interesting. I mean, it's really amazing at how something that looks so simple when you look at marketing material is so difficult to actually do in real life.
I think there's, if you really do the science with 100% honesty, you know that these filters are not going to capture everything. So if you look at the filter porous size, which is 100 micron, what is your filter? I'm sorry?
That's right, it's 40.
40.
That's right.
Think about the 100 micron versus a 40 filter on your pumps.
Yeah.
So definitely we learned that majority, I think we did a study in the carotids, 80% of the material is passing these filters.
Wow.
80. So definitely we need to learn more about, my problem is that if you go down to 40, you may be definitely clogging up because you will collect so much material that you're not going to provide a flow. So we need to find a better way how to filter the materials, 100 is definitely not a perfect size. 40 is probably hard to do.
Yeah, just because of surface area.
Yes,
you're
but
right.
I think these debris, when you're looking at even those pictures, this is a macroembolus. This is a big piece of chunk on that picture.
Yes.
You're not going to see these with your eyes. So I think the same thing how we see DWIs, subclinical stroke, these are probably need to look as a really tiny pieces. So TCD will pick up something bigger than the red blood cells. Red blood cells 7 micron. So think about 7 micron to 100 micron. So definitely there's a huge room for the debris to really size them up, and I think the sizes does matter. I'm so sorry to start start an early morning conversation, but after the elephant joke, I think I'm ready to go on pump.
Thank you very much. So, you know, these are really, really incredible, interesting points. But, you know, one of the things, and I'll get to my slides here, but one of the things that I find fascinating about all of this, it's not only about embolic events, it's flow. And we just always seem to talk about emboli, but we don't really talk about flow. We don't talk about capillary opening pressure. We don't talk about the resistance to flow caused by venous congestion, for example, as I was mentioning earlier, and how that affects the flow patterns through the brain. So we keep focusing on this embolic phenomenon, but we don't really think about or talk about it's about flow. It's about flow, it's about your CO2 level, it's about your oxygen carrying capacity. All of those functions are relevant to this conversation.
Yes, and I cannot wait to show my slides, which is going to list you the hypo and hyperperfusion. So I think we really need to study the flow as how the hyperperfusion affects the brain, but also sometimes the luxury perfusion, the too much flow, it's not good. So I think we need to learn a lot.
Luxurious perfusion.
Yes, sir. So I think the cooling part and how fast you warm up, those are the time periods. I think the brain is really sensitive, and we shouldn't rely on, well, when I'm cold, easier to control the bleed versus what does it really do to the brain. So I think we learned a lot from all those ascending surgeries when you have a circulatory arrest cases. We do learn a lot from those high complications to how to make it safer and how to control and how to even provide flow for those circulatory arrest cases.
Very good. So not all strokes are caused, you know, by the pump. Cross-clamping the aorta, for example, is a big component. Removing the clamp is in fact touching the aorta at all can create these problems. It could be anatomical. It can be a lot of different things. But the pump is certainly not free of stroke risk. Hyperperfusion, gas or particulate embolic events, hypocarbia or gross hypocarbia, cannula position, drainage, and of course pump failure. All of these things can result in a big problem for us in terms of hypoperfusion of the brain. We know that clamping and unclamping the aorta is a problem. Heart position affects flow, and of course we're trying to help the surgeon get through the operation. And another thing too, something that I just thought of, is there are a lot of some perfusionists, when the surgeon says down on the flow to put the aorta cross clamp on or to take it off, will take a clamp and they'll clamp their arterial line. They'll just put a clamp on it and close it off, and of course the flow goes down, the pressure goes down, and they apply the clamp or remove it. Some perfusionists, and I think probably most, turn the rheostat control down, turn the RPMs down. But sometimes you do it faster and go back up faster. Sometimes you do it a little slower and a little back up. We have no clue how that variation, acute sudden change, affects the brain. We have no idea if we go down too fast, does it create a problem? Come up too fast, does it create a problem? I think it's going to be interesting. If we were to start using this on a routine basis, I'm pretty confident that how we practice would change significantly. We think we're doing a great job. I think I'm the best perfusionist ever walked the earth. I don't want to know the data because it's going to reveal how wrong I really am.
I think you're still best perfusionist, and I think because you're really sensitive for the new knowledge and you're open for the TCD and all this information. And going back to your slides, I think it's very important to not to blame the perfusionist, not to blame the surgeon and also the anesthesia who's in your team, but kind of work together. So I think very important your cannulation site. Surgeons, they learn, well, not just looking at the aorta, but really do an ultrasound on that aorta and look at the other side, make sure there's no plaque there, would be safer cannulation, that you're not dislodging a plaque in that moment when you're just cannulating. So I think those are very important, and I think our anesthesia is always asking our TCD flow information, because when they see any pressure issues, it's so much easier to see how is it affected in brain. And it's stunning how the auto-regulation still works. So pressure change of between 20, it just reacts and the brain compensates with only 10% change. So I think those are the important information, how as a team we need to really communicate, and as well as a surgeon, perfusionist, but also the anesthesia, perfusionist, communication needs to be really strong.
Very good. So do we know whether our flow is adequate? And I think we assume a lot. Cerebral oximetry certainly is something that people use, but I don't have confidence in it. Do we know whether VAD or kinetic assist, vacuum-assisted drainage or kinetic assist has an effect? Does going on with the dry venous line really create the problems that some people say it does, or doesn't it? Is a closed system like a bag better or worse than an open system? When we go on down on the flow, I talked a little bit about that already. How do we do that, and what is the best way to do that? Does pulsing, some surgeons now are wanting us to pulse on bypass, you know, and I mean, you got a cannula that's 20 French. You're really not going to be generating much of a pulse pressure or much of an upstroke, and does it cause more harm than good in terms of cerebral protection for what we're benefiting by trying to perfuse the kidneys better? And how are we managing our temperatures in terms of cooling and gradients and warming and so forth? The brain is very sensitive to hypoxia. We all know that. It's very good at auto-regulating. The cerebral perfusion pressure and CO2 are critical. Dr. Garami is going to give us more examples about that. But it consumes 15% of the cardiac output compared to about 5% for the heart. So the brain is a huge consumer of oxygen. It needs a lot of blood flow uninterrupted to continue to function properly for the patient after their procedure is finished. And has this very conveniently positioned, the brain has this very conveniently positioned vascular system. So I'm going to go through this very quickly. We'll see this more with Dr. Garami. The carotid's coming up, the middle cerebral artery. You've got this temporal bone window, which is very good. Some women, I know you said, have a problem with it, but it's very easy for us to be able to put a probe on there and aim it and capture that MCA. In this article, detection of embolic events, we have, I'm so sorry there. I'm not even sure why I have that in there, so I'm going to skip that slide. But how can we be a part of the solution? Well, look, I think we need to learn more about TCD. I really want to, in my group, in my practice, use TCD at some facility on a routine basis, just to learn what's actually happening. It's, for us, a newer technology. The TCD devices of today are not the TCD devices of the past, and I think you'll highlight that a little bit. They're little laptops, very easy to use. It's also the head frame you talked about, very easy for us to apply. Now, there's complications. We'll talk about that later, about getting anesthesia buy-in with it. I know at your facility you have it, but that's not a private practice facility, and it's problematic for us.
Well, the other thing is, I think TCD as a technology can monitor your line. So right now we're talking about monitoring the patient head, but I think the TCD probe itself can be applied and can tell you, hey, you're sending embolization from your equipment. So I'm so sorry, I'm not a perfusionist, but I hope that behind your filter there's a flow meter or sensing what is the filter function is. So definitely that would be my idea of to really see what your filter functions, how does it work, and do you really filters everything out, or you can really blame on your machine that you're sending debris back to the patient.
Yeah, they do have devices for that. What's the name of that device that we were trying to, I forgot the name of it now. What was the name of that thing? Do you remember?
Yes, I remember, but
Tell
I'm not.
me.
No, I'm not going to
Oh,
say
good
it.
Lord, have mercy. But we have that emboli detection system for the pump that a couple of researchers.
EDAC.
Oh yeah, EDAC, the EDAC. But they're not something that anybody uses, and there's a German company. In fact, EDAC's off the market. There's a couple of them still around. But you're absolutely right. We don't monitor the pump for embolic material coming from the pump. So is the emboli you're seeing with the TCD being generated from me or from the aorta or the carotid or wherever else it might be? We simply don't know. But it has billing codes, so there is revenue generation from it, and I think from what I understand, nobody's going to get rich off of it, but it certainly helps pay the bills in terms of the utilization of the device, the cost of the device, and the time that it takes to actually utilize the device, I would think.
And
but I'm
definitely
not
cheaper than
positive.
pay for the stroke. So I think when
No,
you
that's
have
true.
those $1 billion, when you're mentioning how much is a stroke treatment in the U.S., I think this is where not just making us rich now, it's more about keeping those costs related to the stroke down.
Absolutely, that's very true. But trying to convince an administrator of that, they just look at the cost. They don't think about that. It's very hard to convince them about these protective devices, and if this happens, this is what it will cost. It's very hard to convince them of that sometimes. It is very highly specific for both flow and embolic events. I think it can definitely help change the practice, can be easily learned by perfusion, can be a perfusion tool, which I think would be something that would be fantastic for us as a profession. And I think we basically just all need to get more involved to know what is happening with our patients. So this, I think, says it all. There are no knowns. These are things we know that we know. There are known unknowns. That is to say, there are things that we know we don't know, but there are also unknown unknowns. And these are things we don't know we don't know. Don Rumsfeld. That is prophetic. And in honor of Dr. Garami being our very first speaker, thank you all very much. I think we're going to get a word from our sponsors, and because we've got to keep the lights on, and then we're going to come back with Dr. Garami's talk. Thank you all very much. That was a good session. Dr. Zsolt Garami, the Medical Director, Vascular Ultrasound Lab, the Baker Heart and Vascular, Houston Methodist Hospital.
Thank you, Joe. Hello, everybody, and I would like to continue our TCD lectures with some intraoperative images, and I definitely would like to quote Dr. Lumsden one more time: imaging, imaging, imaging. We do have a fancy hybrid operating room, and probably the TCD equipment is still the cheapest piece in that room. So TCD is what you see in the middle, that yellow box. Sorry, get your, I need your paper, sorry. That yellow box in the middle. But anyway, you see the mouse is
the middle box, the yellow box.
Yes.
In the middle.
Uh-oh.
Nope. There we go.
Yeah, thank you. Maybe. So the yellow box in the middle with the head frame connecting to the head, and this is our TCD screen. We already learned, but if someone came in late, the red signal represents the middle cerebral artery, the blue signal represents the anterior cerebral artery. It means red coming towards your ultrasound probe, blue going away, and all these signals basically the ultrasound 2 megahertz signal reflecting on the red blood cells. These are a few, sorry, I was a little bit too fast. So this is a few papers, what should be our practice standard, and this is something that we already have, practice standard for intraoperative monitoring. But I just want to educate about the perfusion. How does a brain is perfused? And this is like, I think, the easiest example. The top is how the normal flow looks like when you have a low intracranial pressure and your systolic diastolic perfusion pressure nicely flowing a low resistance flow pattern. In a moment your intracranial pressure increasing or your pressure is too low that your diastolic perfusion pressure is matching your intracranial pressure, you're not perfusing the brain in diastole. So if you're just perfusing in systole, that's the spike, it's just not enough for the brain. The brain really likes to have a flow throughout systole and diastole. And finally, this is a really sad part, when you increase intracranial pressure can shut down your circulation. So that's your brain dead situation when your increased ICP is right between the systole and diastolic perfusion pressure. The flow goes back and forth, so it doesn't really progress all the way to the tissue. And I just want to show you an example how does a hypoperfusion looks like. So hyperperfusion means that right now we have a mean arterial pressure of 30. You see the gap in the systole and diastole, and now what we're going to do, sorry, I need to go back. Roger, can you start this movie for me, please? So right now from a 30, we're going to increase the pressure to 80. So watch that blue flow gap between those red signal. So this is, we're going from hyperperfusion and we assume this person is brain dead, and it's not brain dead, we're just not perfusing the brain. So suddenly when we start to perfuse the brain and we raise the pressure from 30 to 80 mean arterial pressure, we have a gorgeous flow to the brain. So that's how why we call the TCD almost like the stethoscope to the brain, that you can really see and listen to what is the blood flow we deliver. So that's where the perfusion is really crucial. And I agree with you, emboli is just one story, but this is how the embolization look like on the screen. On the middle of the screen, that huge dip you see, this is a good Valsalva. The Valsalva, by increasing the pressure in your chest, maybe just preventing the venous return. Mm-hmm. That's the best example. If your venous return is not there, heart would love to pump, but there's nothing to pump out. So that is the main maneuver, what you can really control and see how the TCD blood flow changes. So that's actually done with during the PFO test. And this is how the TCD signal can improve by a contrast material. This is like a contrast agent injected in the circulation. So TCD definitely sees the entire hemisphere, not just that focused part. So what we learned from the carotid surgeries, and again, we had data from the 90s, that the TCDY monitoring the cerebral circulation, we can see the poor collaterals, we can see the embolization, but we can also check the vasomotor reactivity, and but the most important, how we describe the hypo and hyperperfusion. And as you can see on this paper from Dr. Spencer from '97, the incidence of hypoperfusion and hyperperfusion almost similar.
Wow.
So the similarity is coming that if either you have really the hyperperfusion, but the luxury perfusion marker is the double the velocity is 1.5 times of your baseline. And it's scary. We didn't change too much, but in the end of 90s, we had 93% of the cases had microembol signal. And that is always predicting stroke and TIAs after these procedures. This is just a few signals that if you prep your line properly and you do not have any air in it, you can see the flow arriving to the brain, and you can see that brightness. Can I have the mouse just,
yeah,
let's try it again.
Is it on?
Easy,
yeah,
so
there it goes.
on this left side,
Do you have a pad? Does anybody have something, piece of rubber or something that's a little harder? Try the back side. It just doesn't want to. Use my hand.
this may be too romantic, Joe.
Yeah, it
oh
works.
shit, it works. It's really, no.
Oh, then you switch the screen.
No. So anyway, the idea of that you see the brightness improving, that there's another material arrived in your bloodstream, and this is your, probably your prep line or contrast agent something. When you have too much air, that also shows up on the right-hand side. That lots of white line, those are you really don't want to see. And the big piece, which is on the lower image, that you see, you do not want that big piece of chunk, because almost like it's deleting the signal and it's changing your
Right.
flow
So that's
pattern.
so the bottom
Is a
signal.
microemboli.
Okay.
I'm
so
sorry.
how do you
And this-
differentiate? I'm sorry.
Yeah, sorry. So this is the microembolus. When you have like a big piece of chunk and it's immediately changing your blood flow, that you see that your mountain becomes flat. It means that you're not perfusing that vessel. This is immediate occlusion, and with that immediate occlusion, you don't need to wake up the patient. You can tell that this middle cerebral artery or the blood vessel is definitely obstructed, and you need to start your rescue therapy and able to fish out that clot.
So now, how can you differentiate between that and air?
So this is not a question of air or what it is. It has to be a solid piece because it's obstructing the flow. I think it's more about obstructing the flow or not obstructing the flow. And so too much air is not good for the brain. So I remember one of the first case I learned about the cerebral perfusion, the retrograde cerebral perfusion was utilized when you pump with the malfunctioning pump air into the patients. So if you pump air into the patients, what your only option is reverse your flow and try to pump arterial blood flow through the venous system and flush out the air debris. So that too much air, I don't know if you're planning to kill someone, but you need to inject at least 50 cc of air into the heart able to stop the heart. If we are showing you later a video that you were injecting 3 cc of air into your pump, that was embolizing for 2 minutes. But tiny pieces. Oh, I'm going to show you.
Yeah.
I have a pretty video of how the 3 cc emboli, how your connector was played a role. So that connector bubble, what you said is like, there's tiny, less than 1 cc air bubbles. They were embolizing for minutes and minutes and minutes. But they did not affect the flow. And I think that's what's important to differentiate when we are talking about the microembolus versus a macroemboli or something which is obstructing your flow and definitely is harmful for the circulation.
But I'm going to tell you too, I have taught you very well, because you said, you know, if your pump malfunctions and you've pumped a lot of air to the patient, that was very good. It's never the perfusionist's fault.
No, never.
Okay.
I'm going to skip the carotid because I think we are not interested in the carotid surgery. This is just one picture that during the carotid using a shunt to bypass the surgical field if you don't have perfusion. And this is the same thing. If your cannula or the shunt is not perfusing, you can see there's no flow in the brain. And this is just a simple clamp action that you put a clamp on, suddenly your flow is definitely decreasing, and we can immediately see that how the clamp placement and the releasing of the clamp able to help us. So this one is one releasing, sorry guys, let's go back.
Maybe slow down, it might be kind of going
Yeah.
fast. There you go.
So this is a clamp placed in one carotid, but looks like it's a bilateral disease. Both carotid goes down. So I think that's the other important information why we try to monitor both hemisphere. Yes, unilateral change is going to indicate stroke, but bilateral change is going to tell you there's something wrong with your heart. The cardiac output must be decreased. So this is why the bilateral flow decrease, I think, is really crucial information. This is how we monitor bilateral MCAs. But when we're interested in, say, we have a changes in the ACA, we can also monitor the blue signal, the anterior cerebral artery, because the changes of the flow direction in the ACA also triggers that there's a problem with your carotid. And I think for the open aortic surgeries, that's really crucial, and not just the new technology, how we advance with deployment of the stent and how we improving the flow, that's a clear confirmation. So here, why the ACA becomes a good direction, you can see on the bottom signal that suddenly your signal collaterals do not need it anymore, so suddenly your the flow is changes. And this is the hyperperfusion. So when you're releasing your clamp, and remember the delta percentage, we started 100%, and suddenly it shows you 220%. That's hyperperfusion. That's the hyperperfusion is what's going to give you headache and seizure post-operatively, but you can control it in the operating room by decreasing the pressure and also hyperventilation. And this is just few video examples that Dr. Lumsden putting the clamp on. Immediately you see the flow changes. Now he's going to release the clamp, and immediately you see the flow changes. So the improvement of the flow is always our clue that indeed we did a good surgery and our flow is improving. Now we're putting a clamp on and you don't see a flow. This is the time to call for a shunt. So we need to place a shunt to able to provide, but when you place a shunt, and this is why the air is always there, sometimes it's impossible to properly de-air. Even the tiny amount of air is really picked up on the TCD, and then finally when you release the clamp, you see the flow improvement.
And again, and we accept that. I mean, at the end of the day, we accept that. We are, you know, in that particular procedure, many other procedures, we know, even when we do open valves and the left atrium, mitral valve, and the left atrium has, you see it on the TEE, you see the starburst floating around. That is air. And that air is going to eventually make its way through the system. And we just accept it.
But I think we can learn something how to get rid of that air. So we had few approaches. For example, the ultrasound, if you put it on the arch with a high energy, you can destroy those airs. Or you have air maybe coming from your pump and you sensor it, but that sensor maybe with a high pressure ultrasound wave can destroy the air bubbles.
I want to talk more about that.
So
during
those
the
air
discussion
so
period.
those air
incredible.
bubbles, if we capture it, we know they're there. I think there's some technology that we can improve to get rid of them. And I just want to compare the open carotid versus a stenting the same way how we comparing your on pump of cases. Indeed, when we put a stent in, there's debris going to the brain, but also with a recent improvement of how to protect the brain, we can definitely place a protection device that we are really minimizing the amount of bubbles going to the brain. This example that you're just pulling on a carotid, look at how the flow is changes.
But the blood pressure is not. So if you're not monitoring that, you think you're just fine.
Exactly, and I think this is where these video captures are synced, and these are real time, and I think that's the perfect teaching tool for us. And this is, you are deploying a stent. You're deploying, pulling back between those two black dots, What's the TCD signal? You see nothing. It means if you really put your markers down, hey, I do not, with this really sensitive toy of TCD, which picks up everything, and you're telling me that I can deploy a stent without a single embolus material going to the brain? I'm not a marketing guy, but definitely this is the protection I want in my brain if I need a stenting someday. So these are what we learn, and you know, we can have thousands of cases, but this one video clip is more than you know, 1,000 words in the publication, New England Journal, and I think this is where we need to be open and able to share our experience. And I was like, how can we get to this level? Sure, when you're a beginner, even an open carotid surgery, you have a lot of air, but this is a TCD, a perfect teaching tool for our fellows, that you can de-air, send everything to the ECA, but to protect the ICA. And I think this is where we're learning a lot and able to teach them. So this case is we are deployed a stent, and we did not see the improvement of the flow. So proximal, there's something blocking that flow, and we had a tiny dissection, so we had to balloon and put a second stent proximal, and then you're able to see that the flow improvement.
Give it a second. Let it catch up. I think sometimes if you keep clicking it,
can you advance it on my?
There it goes.
Yeah. So you see the flow improvement after the balloon, and I think Oh, here's your favorite.
My favorite, yes. Thank you so much.
Oh, you're very welcome, sir. So this is an off-pump case, and see the CO2 blower came in and suddenly blow the air into the brain. So for us, this is still stunning, hard to explain that how.
But they didn't know this was happening, right? They didn't know this was happening at the time.
Well, we alerted the surgeon, and I think after that we really went through a bunch of different testing the angle of the CO2 blower, what can we do, and also I really like the idea to fill up the cavity with CO2 to try to get rid of the air that way. So I think we do learn those protections, what's the best technique, and I think where we say we have a perfect, most sensitive tool to really compare devices, or if you just go for the proximal anastomotic devices. I can tell you between the two devices which is better. The one doesn't give you shower of emboli, but able to carve out the buttonhole and able to put your proximal bypass in without the air. So I think this is where we can definitely compare these, and this is my favorite, when you initiating the bypass and when your perfusionist de-air properly and you see that the heart is barely pumping now, but your fluid arrived to the bloodstream, you see the density changes.
So it's not emboli because it's at baseline.
Exactly, and there's no brightness, the density change you see. This is when emboli comes. Oops, sorry. This is an emboli. So when you release your clamp and you see a bunch of emboli, and I think this is where really interesting that while we are doing the perfusion, we have a perfect way of really sizing the emboli. So this is where you're talking about sizing emboli. You do have a non-pulsatile waveform while you are on pump. So while you are on pump, you can see the different sizing material.
Good luck.
Yeah.
Good luck.
So thank you for your luck. So let's look at the left button image. When you see the letter A, that's a high speed, probably small embolic material.
So the bottom line, the
bottom
upper left corner, bottom line
is
towards
a big
the left
piece
is an A.
because it's yeah, but when you see something closer to the baseline, this is a slower moving, has to be a bigger piece.
Okay.
Something is higher up in your waveform, probably a small piece because it's traveling at a higher speed. So based on the speed, I'm trying to differentiate them, but definitely what I'm really scared of is the left upper corner. See the left upper corner materials? They are deleting your embolus signal. They are deleting also your blood flow signals.
Yep, I see the gap.
These are huge gaps. These are huge chunk pieces that we are lucky that we still have a flow after them. So this is where we definitely need to pay attention, all those tiny details, not just the big shower of emboli, but this is a good example. So you see the speed higher up closer to the green line, that's a lighter material. The third A is sitting on the middle of the blood flow, so definitely it's a real bigger piece because it's traveling slower. So I have few of those TEVR examples for you, and I just want to show you one of our experience with retrograde cerebral perfusion, because I think we learned a lot from that too. So when you are stopping the pump and you would like to have a retrograde cerebral perfusion, indeed the flow in the middle cerebral artery can be detected in a reverse fashion. So you need to overcome that capillary opening pressure, at least like 40 mercury millimeter, and you can increase the retrograde cerebral flow from 500 up to 600, 700 to open up that flow. After that, you can decrease it, and we can detect the flow up to 450. And I think this is you want to prevent edema. TCD can guide your retrograde cerebral perfusion.
So you're not over perfusing, but you perfuse enough to get the capillary opening pressure, get the flow going, and then you can back it off.
Exactly, and because we are in the barbecue business in Texas, I just want to show you, this was Dr. Safi, Dr. Estrada's slide to train me why the hypothermia is not enough. You need some other protection by the blood flow. So look at this barbecue. So if you just do circuitry arrest, 5 dead. If you do hypothermia, 2 barbecue, and you have 3 strokes, while you do additional cerebral protection, you're going to have 4 healthy animal, and you have only 1 stroke, so you're going to be hungry because there's no barbecue out of that group. So I think that's very important, that how from these animal experiences we can really learn how to perfuse the brain even in a retrograde fashion, so we can change the direction in the middle cerebral artery by a proper cannulation. And because we are adults but we like to play, this is our playground in Houston.
Who's that handsome guy there in the middle?
Not the middle. I want to point out the guy on the right. See that guy?
Hey.
Yeah. Do you recognize yourself from the back? The handsome guy in the middle is our NASA head frame that NASA gave us, and we're able to use that as a cerebral perfusion model for the TCD. The TCD is sitting on that head, and while you guys are hooking up your pump, we were perfusing our head model, and we have a TCD signal placed on that on the head. Oops, can you go back 3? Advance 1.
So these are really
Don't play, just advance 1 slide.
and these are micro,
So I want you to watch the TCD screen, the upper,
or stop the pump so I can see that it's. So I just want to see.
and listen
confirming
to our
that we
conversation,
stop the
because we
pump.
recorded that by.
Good, that's it.
So don't hit that again.
So you are
Put it in a
purposely
wrap.
injecting air to really test it. How
Yeah,
do we
well,
pick it up?
what
And we
happens
also
is this is
played
your-
how to decrease the flow pattern and increase the flow pattern, be able to change the flow. And again, this is provided by your Livanova perfusion equipment. So this is
Yes.
why it's a non-positive flow pattern. And this is where you try to create some positive flow pattern by just like holding the flow back, and you're hitting your
Yeah, breaks
connectors
up.
because
So
you
we
had
can't
some
even
air
count
stuck in your
Does it-
connectors. And I think this is where we really had fun. Can you play this video? We injected non-sphere
They're in.
material size. This is a 250
They're
micron.
coming.
So they went through the circulation, and we were collecting them, and we were watching how we embolize, and we were testing also your filter.
And that's
it's-
through a 40
Yeah, I'm
micron.
trying to
filter.
measure how high does it go, the velocity, and how
And
fast
then you
does it
see the
clear
sudden
out.
stop. So this is your filter function. Your filtered
whatever
them out. So
filter
they
did
were
it,
not
it was good.
recirculating.
Good job.
So I
Now
think that
it's-
was really
it's-
stunning that we tested. The second one was 100 micron. Can you play this again, please? So the 100 micron really able to see it and we
Yeah.
able to get through the circulation.
Not much.
It's a short injection and definitely filtered out.
Mm-hmm.
And I think we really kept your guys happy, but I just really want to show you this because I got you on your knees.
Go.
One.
One time, at least on your knees. So you were injecting, and look at all there. So this was your 3 cc air injection. How we able to detect the flow in? So you're showing. And stunning how the air was like for 3-4 minutes, and you watching your watch, and then we figured out there's an air pocket somewhere at the connector, and this is why it was non-stop embolizing. So that air pocket, what was sitting in your circulation, was stunning.
Yeah, well, it's in it's in the circuit itself, and of course this was crystalloid that we were using circulating around through this head. But at all of those connector points, that air will hang up, and it'll just continue as we keep hearing this shower little by little by little by little by little until it is gone. And so I think that's you don't see it, you can't see it, but it's there, and this proves it.
Yes. And I think the happy moment was when we injected the 40 micron, it filtered out, so we have that clip too that definitely filters everything out. So going back to the TAVR, this is when a TAVR DWI lesion started to show up in year 2009, 2010. Look at it, 86% of the patient, they had these DWI lesions.
Wow.
So compared to the surgical, which is about 50%, but definitely smaller lesions. And again, in Europe, they were ahead of us, and in Europe, we got this data from Germany, 2010, and they did DWI and also did TCD monitoring. When you did TCD monitoring, compared to the different companies, valve and the different deployment as balloon-assisted versus just self-deployed, and also the TA, that's this transapical approach, you really don't see differences. The total emboli count is there, but it's interesting that the self-deployment is that the implantation alone is the majority of the embolization happens, why the Edwards valve, the sapient, when you positioning the valve, you have the highest number of embolization, and those are showing on the P statistical significance. I have few videos for you, and this is the first one. We just do the balloon valvuloplasty, and this is the submandibular monitoring, because you see sometimes the balloon is quite stable, is not moving too much. But here we are deploying the core valve, and you see lots of embolization, and you can see the wires that we are not the first guys in this heart. So you can see the history, and you can see how the valve now is deployed on those chicken wires. And I think the videos synchronize what you see on the C-arm and what you see in the brain on a TCD is first, and the best example you're going to see now with a fast, rapid pacing before we see this rapid pacing.
Yep. Yeah,
Beautiful
you see it on the top
BAV,
left.
you can see, and again, you need to deflate your balloon before you stop the rapid pacing, and then you're lucky that you stopped the rapid pacing, the heartbeats came back. This is a beautiful, great examples how the BAV, but also you see that the diastolic velocity kind of giving us a clue how good was this BAV, how good is the valve implantation, how good is the end diastolic perfusion is for the brain.
So in that case, you've got good flow.
Exactly.
Because your diastolic pressure is not going to baseline or below.
Exactly.
So good, nice, open valve area.
And right now, watch when the valve is arriving into the aortic valve. See how the diastolic flow just disappeared? So you're blocking your outflow tract, sure. You're not going to see diastolic perfusion. You want to deploy it, so you want to help the perfusion in diastole. This is a short period of time. You want a faster deployment for sure, but this is just giving you a clue that how the flow is changes while you even have your TAVR in the aortic valve. So this is the not that lucky moment, because this is another balloon valvuloplasty you're going to see. And in this moment, you have a balloon going up.
You're 200 or 160 or?
And after balloon is
180.
deflated, you do not
Okay.
see the heart start
Negative.
beating
Stop.
again. So this is what we can see and experience. What is the CPR
we need to please
or
the
the
pet.
VTAC can do to the brain.
Okay.
So
Well, it's
meantime, here
VTAC,
you can
okay.
see on the bottom of the screen the CPR starting, and later I can show
Okay,
how
the
does the
pet
flow
wouldn't be a good
changes
idea.
during the
Do you
CPR.
ever
Yes,
measure
maybe we
gradient
can-
after
okay.
valvular
And this is
plasty?
how
to the
the
screen, your
rapid
Okay,
pacing
we
started.
see.
And after
Both
the
sides
rapid
flow.
pacing
MCA
stopped,
Normally, no.
is
you
gone.
do not
There's
have
a
a flow
return
coming
of
back.
one heartbeat, and
So
then we
this
go
is
to
the
flat.
VTAC period started, and
what
this
was
is
very
where
important
interestingly
that
the
again,
CPR
you
and
see
the
the
flow
VTAC
improvement you see
waveform in
when the
the
heart
middle
starts
cerebral
beat
artery
again.
after just one heartbeat.
Almost like a most
You see
sensitive
that
EKG you
vibration
can
on
see,
the
but
top of
this
the
pulse,
waveform.
what you detect in
And
the
this
brain
when
is
Dr.
stunning.
Rainer
That this is
made
your
a call,
VTAC, you
and I
have
just want to
flat
show you the next waveform
TCD
because I
signal,
think it's really gorgeous
and the
when you
first
have
moment the pulse
successfully
comes back,
restoring the flow.
it's stunning
This is
how
when
much
the big
air is
shower
trapped in
happens.
that stopped heart. And
But
Here's
again,
here
you
comes
see
your
that
first
both
heartbeat.
hemisphere gets a flow back, and both hemisphere has a
That
pulse.
just
effect.
showers of
You
air
can tell this
bilateral.
is
And that was
emboli
just
or
air, 'cause of
something
course
went up
this is a
probably, or
TAVR.
it's just that flow comes
So that
Um,
air had to have been in the catheter, the deployment catheter, the valve itself. I mean, it had to come from somewhere. It certainly didn't just create itself.
And I hope it's just there, but definitely there's
So
a
we don't
picture.
know.
Definitely
You're
there's a debris.
So you're saying it's air, but it could be
Yeah.
it could be particulate.
And this is my stunning how the brain not perfused. So here's your valve sitting, and you don't see that usually mountains and anything. So this is again, you do not have a brain perfusion. When you do not have a brain perfusion, you start CPR. So this is our fellow hand on the left-hand side. Wanted to make sure the hand is in the proper position, and I want you to pay attention how much the CPR flows to the brain. Tiny, tiny spikes, and I think after our young fellow got tired, we got our senior surgeon. Look at the highest peaks. I'm not going to name our senior surgeon, but I think Dr. Reardon will be really happy to see the flow
There it
pattern.
comes.
So we're cannulating the femoral artery now, and you see the perfusion starting, non-pulsatile flow, but we have too much air. So we stopped the pump, and we said, okay, let's check connections, let's de-air, and start our perfusion slower. And why we de-airing? Look at the slow start on the perfusion, how we really minimize the air. So I think that's why the immediate feedback to saying, hey, that was too fast, that was too much air, and try to slow it. I think this is a perfect example how you can direct your blood flow. I think I'm going to skip this one, and because we're running out of time. Let's see this deployment. So this is a Edwards sapien valve. You can see it's the sheet going, and we have the pigtail and aortic valve, and now we're trying to go across around the arch.
And you can see it pushing. You can see it pushing
Can you
against
fast
that
forward
wall.
a little bit, Roger? Just on the clip, if you can. Fast forward, so see the valve crossing the arch. See, here comes the valve crossing the arch. Okay, slow it down. You see few embolic material goes to the brain right away. So that is your example. That definitely not as your cartoon showed that your valve is staying in the midline. It's bouncing, and again, how you're taking the turn despite that you have a clever bolt to take that turn. This is the embolic material. This is was no protection used. Ends up in the brain for sure.
It's a little jackhammer all the way around.
Yes. So this is when, let's see the next one, please. And this is, again, a synchronized video. Can you play it for us, please? And watch the TCD on the left upper corner is the right side, on the bottom is your left side. And here comes the TAVR crossing your arch again. And this is the core valve, a little bit longer. Look at the materials going to the left side. There's not much material going to the right, but you are embolizing and trashing everything to the left hemisphere. So why we are passing in the arch, so we're not even close to the valve, but we had major unilateral embolization. And after this unilateral embolization, I am losing signal. I lost my left MCA signal and few debris going to that left MCA, but you can compare to the upper screen on the right side, you still have a flow. This is stroke happening in front of your eyes, and I do not need to wake up this patient. So this patient transferred to the neuro intervention, and with 30 minutes later, after a quick deployment of the, can you advance the slide, Roger, please?
Let me see that thing.
Can you go back? Okay, we skipped it. So the answers are there. Definitely there's a bunch of different embolic deflectioner filters. This one of them is the umbrella, and you showed the other device. And we definitely studying these as not just DWI lesion is less and where are they, but also if they can decrease the embolic load. So you can see in this case there was like 820 with a control group, and we decreased them half, so almost like 340 by using the umbrella, the TCD count. And this is the umbrella deployment from the right arm. So when you deploy the umbrella, and this is the first case was done in Germany with TCD monitoring, and you're able to protect the brain with that
this is what we expected
filter,
to see.
and now we are deploying
No
a
sharp for sure.
valve
pull
with
back
that
the balloon,
umbrella protection,
Watch the device
and
up
definitely you see less embolic material.
Uli, what size
And I
balloon
think
was that?
that's the
It was
clean
a
way of to be able to
22,
really
22.
study different cerebral protection to really show it in the most sensitive way of that the TCD do not
notice
show
he
you
did the valvuloplasty
embolization
in
while
the
you're protecting the brain.
AP view.
So I'm just looking for my last slide. I want to skip these. We saw enough examples. With Dr. Lumsden, we try to bring TCD in the suburb hospitals. So we try to provide monitoring with this remote proctoring. This is a Storz InTouch device that Dr. Lumsden able to see the TCD remotely, and we able to help and can you advance, Roger, please? So this is the TCD device in the operating room, and this is the I'm remotely able to control, and this is my remote view that I'm able to see the operating field and also the TCD, and this is my head just behind the surgeon to be able to present from hundreds of kilometers away to remotely able to assist. And again, thank you so much for the invitation, and thank you for providing us some fun. And definitely I had to mute all that fancy noise, but definitely there was lots of laugh, and this is why the people should come to your conference if you want to learn more.
Well, that was very good. I like that. Thank you very much for that. Okay, so Roger, could you put our number up for calling in? And we'll go to a commercial break. Dr. Mettauer just got here, so we're going to bring him up to the table as well, because I think you can weigh in a little bit on this TCD stuff. I'd like to be able to implement this in your practice. So if you're going to call in, go ahead and call. We're going to go to a quick commercial break, and then when you get back, we'll take some phone calls. I think we have some YouTube chat, and if we have any questions or you want to discuss any of this with Dr. Garami, Dr. Mettauer, or myself, please call in. The phone lines are open. Okay, and don't forget, there's a 20-second delay, so turn your volumes down and be a little bit patient. If you call and the line's busy, just call back. Thank you all very much. Good. So play all.
Optiflow arterial cannulae. Less jet, more natural dispersion. Neurologic complications during on-pump cardiovascular surgery are often induced by mobilization of atherosclerotic plaques, linked to enhanced wall shear stress of the arterial
Good morning.
cannula jet flow.
I can't hear it, Roger. I can't hear it.
Optiflow arterial cannula features a unique basket tip with large openings that allow a more physiological flow.
Give me the phone. Hey. Hello.
Optiflow arterial cannula has shown to reduce the pressure on the inlet jet system on the aorta, thus mitigating arterial embolization of atherosclerotic plaques. After purse strings have been positioned and the incision in the ascending aorta has been made, Optiflow arterial cannula is inserted, then turned towards the aortic arch to allow a centralized flow. Optiflow provides optimal dispersion flow with no jetting compared to a standard tip cannula. The dispersion flow of Optiflow reduces the wall shear stress values by approximately 50% compared to a standard cannula, with the potential of reducing ECC complications such as strokes, endothelial damage, and hemolysis. Optiflow arterial cannulae are available with straight and bent tips in 21 and 24 French sizes for all patient needs. The unique basket tip design reduces the pressure gradient along the cannula, thus improving blood flow dynamics. Tubing is DEHP-free for a clear and more transparent look and feel, available with and without wire reinforcement.
First caller. You got your mic on? Yeah. Mic is on. Should be a green light.
Yep.
Yeah. Mic is on. Hello?
Hello.
Hey. Oh, we lost the girl, or the lady. We got to call her back. Oh, she's on hold? Yeah. Oh, okay, well, we'll go to you first. Hey, how are you? Who's this?
This is Patrick O'Toole.
Hey, Patrick, what's going on, man?
Good. We're not live right now, are we?
We are live.
Oh, great. Well, I have a question then for Dr. Garami.
Yes.
Okay. So, Dr. Garami, can you see the difference between an air embolism and a particulate embolism with the TCD?
Depending on the mood and depending on the device I'm using, few companies claim that with two different frequency on a TCD, you can differentiate, but in my experience, I think these devices still fail to differentiate. 50% of the time, they are rejecting even thinking about it. So if 50% of the time, you don't want to even differentiate, I think that's a bad move. So we tried 2 and 2.5 megahertz on two different frequencies to see the different signature of air versus solid. I think we're not there yet. So we continue our research and trying to find a better tools, how to differentiate those signatures between solid of air emboli right now my commitment is I'm counting emboli, and the total emboli count what for me is matter.
Okay, great. I have a follow-up question as well. At some of the hospitals we're using the cerebral oximetry, of course, and it does change what I do behind the pump a little bit, especially if we're doing a circulatory arrest type of case. But if we were to start implementing the TCD on a regular basis, how do you think it would change our practice specifically? What would we do? Would we be flowing less, flowing more?
Yeah, before we go any further, I would like to ask you, what did you observe on a cerebral oximeter when you're cooling your patient?
Well, we definitely see a decrease in the oxygenation of the brain.
No, your cerebral oximeter goes up. So when you're cooling your patient down, sometimes you see unrealistic changes. So not just by decreasing the flow, obviously you're going to see decrease of oxygenation, but when you're cooling your patient down, sometimes you see the increase of your NIRS cerebral oximeter. And I think sometimes my explanation, sure, maybe it's less metabolism. This is why you see higher counting on the NIRS. But I think if you ask an expert on NIRS, say, oh, my device is best. And I just wish that we have more than one sensor. So when you have just two sensors on the forehead, 1 inch depth, 1 inch is not covering majority of my middle cerebral artery territories. Mostly it's covering your frontal lobe and maybe some ACA territories, not even MCA territories. Why my TCD signal is properly placed in the proximal MCA, I'm going to cover 80% of the flow going to the brain. Definitely, we can improve our monitoring to monitor the vertebrovascular system as well, so you cover the posterior circulation, which may be even more sensitive for embolization than the carotid system. But I feel that better coverage is better. So that would be my simple answer, going to deep details, comparing your present tool, monitoring your flow versus a TCD. And I just think our issue is that when you buy a TCD device, the company just want to sell you a box. They don't want to sell the knowledge. And I think we need to continue the education efforts what Joe does to really give you the education, not just to buy a box, but to really understand what that box shows you. And again, after a few months, few years experience, you will definitely be comfortable seeing the TCD screens and what you observe. And I think it's a tremendous help how you will direct your pump, how you de-air, and how you provide flow during your cases.
Hold on. Do you see a difference between when you do retrograde cerebral versus antegrade?
Oh, big time. Because this was one of the video I showed that when you do the retrograde cerebral perfusion, you do have a filter function. While you do the antegrade cannulation, there's no filter function. So with antegrade, even bilateral carotid or axillary cannulation, you have bunch of debris going up. So I think I'm a big fan of retrograde cerebral perfusion for the purpose that I can direct the pump after opening up the capillary perfusion pressure, that yes, you can dial down, and maybe even 400 is enough. You don't need to shoot 600 or 700 for retrograde. If I see the flow, but my flow is confirmed, not just like dripping blood into your operating field, but I can really see that it's really reached the brain. So I think on the retrograde cerebral, we can find some collaterals that you assume you're perfusing the brain. No, you can come back from the ECA and it comes back to your venous system. The true confirmation that indeed you see the MCA flow direction changed and you detect that flow in the brain, I think that's the true perfusion. So I think that's the difference between doing a cerebral perfusion versus monitoring the cerebral perfusion, make sure it's really there and reach the brain.
Eliminating the Gestalt theory. Just kind of, it looks good, there's blood coming out. And
yes, and I think I remember there was a Austrian gentleman who warned me after we first published that the TCD can detect the flow with the retrograde MCA. It's like, well, you're going to balloon all the brain, and this is Dr. Schilling theory that we are causing edema. We don't see that edema if you're clever and you dial down your perfusion after you detect the flow. And I think that's where the cerebral perfusion has to be confirmed. So we shouldn't assume. I learned this favorite word is like, we assume too many things. We shouldn't assume. We just detect it. We will objectively measure it.
Well, I mean, I think that's exactly right. We just assume a lot.
Right.
You know, you cut the aorta open, and we're going retrograde, and we see blood coming back. So we assume that's adequate flow because we see blood coming back. But is it really globally perfusing the brain?
Yeah.
And I think that's the issue. I think that's what TCD offers. Okay, Patrick, thank you very much. Can we go to our next caller?
Thank you, Patrick.
Thank you. Thank you.
Hello, you're on the air. Hello?
Oh, my name is
Hey.
Dorina.
Hey, Dorina.
Yes, I have one question. My question is, what are practices the cardiac surgery team can implement to minimize stroke with TAVRs? And because you mentioned cerebral protective devices, and my question is, should this be used in TAVRs, or are studies needed first to support this practice as a best practice?
So let me make sure I got your question right. We had a little bit of a difficult signal. You're asking whether cerebral protection, embolic protection devices should be used on every TAVR, and whether it should be used for just standard cardiac surgery. Is that what your question is?
Well, it was mainly for TAVRs.
For the TAVR. So, you know,
Because you said that with TAVRs there's 100% stroke.
there is. If you were to measure, so there's the new stroke classification is you have type 1, which is that obvious stroke that we talked about. You look at the patient and they're in the bed and you know they had a stroke. And then there's the type 2 stroke, which is the new classification, which is any new lesion on DWI. And these are the subtle changes that you see in patients, and they're both cumulative and ongoing. And sometimes they even get worse over the course of time. And when the cardiologists, when they're studying any new device in a clinical trial, they now have to, I believe this is correct, you correct me if I'm wrong, but they have to consult the patient and advise them the difference between class 1 and class 2 stroke, and that their risk of stroke in the class 2 is essentially 100%. Is that what I'm understanding?
So indeed, there's certain trials demonstrated 100%. Majority of the data I showed today, there was like 86% of the patient had DWI lesions.
Right.
And indeed, if we have an FDA-approved protection, it still sounds like a choice for having a protection or not. And I think what I hear from your question was all of the TAVR should be done with protection, and I think I'm on that side, that if we have an FDA-approved device for that indication, all the TAVR should be done with cerebral protection when we know what our complication. And I think this is where we need to go back with our honesty and saying that with the 100% DWI type 2 stroke, we saw the decline of 10% clinical stroke down to 3%. But I think the clinical strokes are still, 3%. We're going back to our accepted complication rate should be 0. I think we still have room to protect the brain, and at the moment I do not see the cerebral protection used in every TAVR cases today.
I mean, that's 3 out of 100. That's a lot.
Yeah.
That's a lot. And let me throw this at you. So first question, or first added question to you is, okay, thank you. We're short. We're running a little over, but I hope you all don't mind. What's going on, dude? Did we finish that? Oh, I think. Well, let me finish up on this thought, if I can, and I'll be right there. She was asking whether every patient that's getting TAVR should have embolic protection devices. Should every patient having TAVR, regardless of where they are, have TCD monitoring? That's to you, and then I have a question for you as well.
Today, I would say it's impossible. I think there's so many centers doing TAVR, and they're focused on TAVR, that the TCD is not a potential equipment available for everywhere, but it should be a best monitoring for stroke prevention. So when we're talking about stroke prevention, when it's really count, we move the patients from general anesthesia to awake patients. So I think that's also changed our method of monitoring. If you do have a awake patient during the TAVR, that's the best neuro monitoring, because you can ask the patient, how are you doing? Count backwards, and again, have a direct communication to the patient. You can see the clinical stroke that way. So I'm on a awake patient, I see the best monitoring is talking to the patients. When you do have general anesthesia, I think TCD it's a must for every case.
Well, I'm not getting TAVR, and if I do, I'm not getting it awake. I can assure you of that. That's not going to happen. I don't want to know what the hell's going on over there. So,
or you want TCD on your head, so that's your other choice.
I want something. So let me ask you something. As a surgeon, you go in to talk to a patient. Would you? How are you going to approach saying to them? Let's say you were a TAVR advocate. How would you go in and explain to them? Look, we want to do this TAVR on you. We don't want to do an open procedure. Which I think is still better, but we want to do this TAVR, and you've got an 80% to 100% risk of having new lesions in your brain, which could result in a stroke or cognitive dysfunction or whatever it is. How do you reconcile? How do you do that?
Well, I'll just give the analogy to SAVR, surgical AVR, which when we had Embolics available, every aortic valve I did, not every cardiac case, I put an Embolics in. I sent off the filters for the first 2 or 3 years, and they always had something. Only 1 or 2 times anything, as big as your fingernail, but that does happen as well. And I would counsel them, and I literally would spend the time with them and say, look, I'm putting a filter in. It may or may not get paid by your insurance. So if you're okay with an extra $300 being charged to you to minimize or decrease the risk of stroke, if you were my mom, I'd do it. And so I put it carte blanche into everybody. And just because of that experience of always seeing something, microscopic, macroscopic, and knowing that there's always something, whether it's clinical or subclinical, going to the brain. And that's without TCD monitoring, that's without cerebral oximetry in a community setting. Again, it just makes sense. You're scraping out a valve and putting one in, and now you're in a TAVR situation where you're not taking the valve out. It's a little less controlled, although it's borne out to be a very safe operation. I would filter everybody. I mean, if it's available, I'd filter. And there are a lot more filter devices available for TAVR than there were for open SAVR.
Yeah, absolutely. You want to go to our I think we have time for one more call. Roger? They hung up? Do we have any? We have anybody else? No? Okay. So listen, I want to, let's transition out of this, I think, with just some music, and we'll take a break, and then we'll put Dr. Mettauer's video on that he can narrate about the mitral valve, simplification of minimally invasive mitral valve. I want to thank everyone for attending this session. I want to thank particularly Dr. Garami for coming all the way up here from the big med center in Houston Methodist Hospital, and giving us a great, I think, overview of TCD and its application. I'd like to see it used more commonplace. I'd like to see us using it and seeing what we're doing. Going back to there's these unknown unknowns, as Don Rumsfeld said, and it'd be really nice to know what we are actually doing, and if it would change anything that we are doing, whether it be the tools that we're using, the conduct of the perfusion, pulsatile flow, vacuum assist, non-vacuum assist, whatever it may be. I would just love to know, and I hope that it comes a point in time where TCD becomes a standard of care for any patient who is going to be undergoing a procedure requiring the use of extracorporeal circulation. I think it's extremely important.
I'd want it.
Yeah, I agree.
Thank you very much.
So much.
Thank you, sir. Thank you.
On YouTube when I was driving in. It's pretty good, man. Like the live feed.
Let me know when we're live on camera. And welcome back, everybody. Okay, so for our next session, it's going to be on simplifying minimally invasive mitral valve surgery. And Dr. Mettauer is going to start us off. We've got an exceptional team panel with us. Of course, to the left of Dr. Mettauer is Stephanie Ibus, and she is a perfusionist extraordinaire who's become an expert at the art of systemic hyperkalemia and removing the potassium. To my right, of course, Mitral. He's the male version of the perfusion extraordinaire. There's a female version and a male version. And Clint Robertson, my old friend from Alexandria, Louisiana, who I've known now for about 12 years.
I think so.
12 years.
That's crazy.
Yeah. He used to be young and good looking, but now, that's my job.
I'm starting to look like Joe.
Do you have hairy ears?
I don't know.
I think you're growing some hair on there. Okay, so we're going to get moving. I think Dr. Mettauer is going to do some narration on a procedure that we did for him here at CHI St. Luke's, the Woodlands Hospital, where he is the chief of cardiac surgery and medical director. And he's going to narrate this and talk a little bit about just minimally invasive mitral valve surgery and how that is just such a beautiful technique compared to the sternotomy for isolated mitral valve. Okay. Rod, you ready? Okay.
So basically, we have your ideal patient here, and we'll talk about some of the other body habitus that you can utilize with this technique. When I was approached by Joe with this several years ago, one of my colleagues that I trained with, Chance DeWitt in Louisiana, was doing some of these in some of his higher risk patients that were redo and not wanting to do a redo sternotomy. And femoral access for this is key, so that's one of the things you have to evaluate in utilizing fem-fem bypass. But I trained with Dr. Cooley. His quote was, the KISS method, keep it simple, stupid. And I trained in more of a traditional cardiac surgery type program where sternotomies, big incisions, etc., and didn't really have any reason to try a minimally invasive approach other than the public kind of starts demanding it, and where we are in the Woodlands, which is kind of like the Beverly Hills of Texas, you start getting some pressure to do these types of things or you end up losing the cases. However, so Joe introduced me to this technique. You can see here a little axillary thoracotomy. This is a little bit generous because it's one of my first ones. and you're basically going about the fourth intercostal space. And the reason I even considered this technique was the simplification of it. Not that it was a new technique to repair or replace a mitral valve. It's well established. It was taking the load off of me as the surgeon and, very importantly, the anesthesiologist, and putting all the burden really on perfusion. And they're the experts in perfusion, and this shouldn't be terrifying, because the very first case that Stephanie did with me was her very first time to do it. So the learning curve is extremely steep. A couple of cases and you got it. From a perfusion standpoint, from a surgeon standpoint, the techniques are there. If you know how to do a mitral valve, you're going to love the exposure. Most importantly, from a surgeon standpoint, is the technology for access. You can see here I use S-Tech. You can use pretty much whatever minimally invasive type of retractor system. I've even used 2 FIAs, small finichettos here, but the main component is the atrial lift, and we'll show that in a minute. I don't use port access. We're not going to utilize an endo balloon. We're not going to put in a retrograde cerebral artery catheter, which slows everything down, because those can be difficult to place. And it also, again, puts that burden on the anesthesiologist while you're sitting there drinking coffee. And for me, I've got a full day usually, and I can't spend all day doing one case. I cover multiple hospitals, although this is my main hospital at CHI St. Luke's, the Woodlands. So you can see the phrenic nerve easily here at the bottom part of the incision. This one, I used Alexis, which is utilized by the general surgeons and robotic surgeons for hand-assisted surgery, so nothing fancy, relatively cheap device. You can go, I've even started using the smaller Alexis because it creates a lower profile, especially, believe it or not, on your larger patients. The largest patient I've done with this is about 6'5", 6'6", and was about 350 pounds, and he was big all over. And this guy had a massive chest, and that was about the limits of the instrumentation. We did have to use some of our long bariatric laparoscopic instruments to kind of help in that from the the gastric sleeve operation types from our general surgery colleagues. But it was definitely doable, and the results, even though it took about an extra hour longer, it was a repair. He did awesome, and to do it through that incision for him, it's going to be hard either way. The sternotomy in that guy is going to be difficult because Dr. Ott, David Ott down at Texas Heart, always said mitral valve surgery generally is your hardest, most difficult procedure to do in the chest. And I tend to agree with that, although there's some easy ones through a sternotomy, but this way the exposure is excellent. So what we're seeing here on the TEE images is the severe regurgitation. This particular gentleman had previous mitral endocarditis, had perforated valves. We had originally planned to try to repair with core matrix and even put a ring of core matrix in to keep everything clean from a tissue standpoint, because he had an acute component to this. However, when we got in there, the valve was irreparable. It was really quite disgusting. So here we are priming the femoral artery and femoral vein cannula for bypass. Obviously, key to get the air out. I don't use transcranial Doppler. We've tried to get it in. It's as a community hospital. There are costs to consider, but I think once we get to a point where this becomes more of a mainstay, that shouldn't be a problem. So this particular incision here, the bottom one, this is one I use for multiple different instruments, but most importantly during the case, using your pump sucker to retract and to give you additional suction. The drawback of this technique, because you're not cross-clamping, is that if you have more than 1+ AI, aortic insufficiency, the amount of drainage into your field is high. 1+ is a lot of drainage to almost moderate, but with this sucker and a weighted drop sucker and appropriate angle and lift on your atrial lifter, you can usually control it enough to be able to see what's going on. And for me, you can take not all day, but you are continuously perfusing the coronaries with oxygenated blood, so you have a rest because your systemic potassium is 10, 12, 13, whatever it takes to stop the heart, 18. I know it's crazy, right? But you're getting oxygenated blood to the heart. You're basically just shorting it out, but the tissues are getting perfused, and they fly off pump. I mean, it is the smoothest transition you've ever seen when Stephanie or men start doing their job in the back. Again, the burden is on them, and they've taken the burden off of anesthesia and the surgeon. You're not on a time limit other than a pump run. So I consider this basically like, ECMO, doing heart surgery on ECMO. And you know how long you can do VA ECMO on people. You can do it for quite some time. So here we are looking at, we're on pump. We have a nice sharp QRS interval, and we're starting to slow the heart rate down.
Yeah, I think that's Basher's mic, and I think she gave potassium.
Yeah, and once you give the potassium, you have almost immediate arrest. Okay.
Can you talk about the atrial lifter real quick?
Okay, the atrial lifter, yeah.
What happens when you don't have it? You try to hold it by hand.
Well, the first one I did, that was the only thing that the Aztec company, before they were bought, they didn't bring the atrial lifter part. So I had my partner holding a handheld lifter from the Mitral set, and it was miserable. You can't, there's just no way to have somebody, well, I guess if you have the perfect assistant, you can have them hold it, but you got to have the atrial lifter. Again, you're taking this out of the hands of a person and putting it into something that's not going to move throughout the case, because you got to have the atrial lifter. That is the key. I don't care. Edwards, I think, makes one that we've used before. For me, it's this. I'm sure Dr. What's Miami Instruments? The guy at Texas Heart downtown now.
Dr. Lamellis?
Lamellis, he has a set that he uses. So, but they're all basically the same as far as the atrial lifter. You got to have it. Okay.
Hey, Raj, can you go back on that to that echo, that black and white image that was just about 10 seconds before this? Because I think you want to comment on that.
And I'm thinking this.
There you go.
And I'm thinking also this particular guy is like, now you got to be careful putting this in so you don't hit the mammary.
Yes. Yes.
If you hit the mammary, it's a problem. But anyway, and we did, and had to fix it. Or clip it. But anyway, so you see the handheld sucker here. That's actually pulling down on the posterior aspect of the atrium. We're a good 2 centimeters in front of the phrenic nerve. You want to stay away from that. And there's the atrial lifter. You can see the metallic instrument in there, and it's on a post on the contralateral side of the bed. There's CO2 coming in from about 2 o'clock, and I'm using a lighted sucker by Invuity. And I use those on aortic valves, mitral valves, because I really don't like wearing a headlamp. I do wear one on a mitral. It's about the only case in a thoracotomy for lobectomy I use a headlamp. So you can see, I mean, you got a direct shot in. The heart's perfectly still. This valve is garbage. We test it. We look at it. This isn't going to be reparable because almost all of the valve is diseased. And the annulus is calcified too. So for him, and we counseled him beforehand, the 50-50 repair versus replacement. My repair rate is about 80%. It's not 90 or 95. And I use the Dr. Lowry method, generally speaking, to repair valves. I don't cut any leaflets out if I can help it. I think you need to utilize the tissue you're given. And even though I trained at Texas Heart, I'm open to new techniques. So
clearly.
All right. So visualization here for me is great. For the video camera, I'm trying to get out of the way a little bit. But again, I think we've made the decision to remove the valve. If there's any posterior leaflet that's normal with chord A, I leave that. And again, that's surgeon choice because, as we know, we like to leave some of the chord A intact. But again, this is a heavily diseased valve. If it's just a floppy myxomas valve, those are pretty easy to fix. Barlow's type, I think those are great actually to just repair. But again, we're sitting here chatting and talking, and you're not under that time constraint of cardioplegia being administered for me, I do it every 10 minutes. Most guys do it every 20 minutes. Back to what we talked about using retrograde perfusion. whether it's in the brain or in the heart. Do you think, does the right coronary ever get perfused with a retrograde cannula? If you have an antegrade cannula in, that's more tubes and wires. You got chitwood clamps all through this small hole, and this hole can get smaller and smaller when you don't have all of that instrumentation in there. So you saw where we removed the valve, multiple fenestrations, just a goodness awful looking thing. And here's Stephanie being attentive as usual, and we're still flat line, and I think we're about to start coming off. And did we cool this guy? We did cool him pretty good.
We're about 30.
And that does help with the amount of potassium that you give, and as far as being less. But we've given upwards of how many milliequivalents on that big guy? Was that a 600 or 800?
That was an outlier. We probably gave about 550.
Yeah, yeah. So that's what we call in Texas a Huntsville dose. And if you're from Texas, that's where you know, we still believe in the death penalty, but it's compassionate, and that's what they give them. So that's what you're basically giving patients is an intravenous dose of high dose potassium, and with the aid of the heart-lung machine and a competent or moderately competent aortic valve, you can perfuse the heart, and it just you really don't get ischemia, which is the best part of this. And especially if you're on a learning curve to try to learn how to do minimally invasive, I think this would be a great way to start because it is simplified. Maybe if you wanted it to progress to something more advanced where you're doing a guy that has moderate AI and maybe look at a more normal technique where you're cross-clamping or using an endo balloon or something like that, then that could be utilized as well later on. But this is for all intents and purposes, the perfusionists are your training wheels. You can be rest assured that the heart's getting perfused and you're not under the time constraints that you normally have. Now, if you can see here, there's a fair amount of perfusion, there's a fair amount of blood in the field, but this is controlled with the weighted drop sucker and that pump sucker that's retracting down. This was our kind of almost moderate AI patient. Mm-hmm. And I've been pushing the envelope with that because at the bottom of the day, or bottom of the line, end of the day, if it doesn't work out and you can't see because there's too much drainage, you can still convert to a sternotomy, and you haven't had an ischemic period. So you close it up, and I have done that. In my very first case, when we didn't have an atrial lifter, I did that, and the guy did fine. Not ideal, but I did tell him that would be possible. I don't tell him now because we've gotten good at great patient selection. So the next best thing ever invented most recently, and I think most heart surgeons will agree that have used it, is the Coronat. You got to have a 2-0 braided suture. I still use the David Ott method, which is 12 sutures for a replacement. Aortic valve, if it's 21 or less, it's 9, 3, 3, and 3. If it's 23 or higher, it's 4, 4, and 4. It works great. It's simple. It works for pretty much everybody. So here, 12 sutures. The Coronat comes in a pack of 12, and this easily shaves off 30 minutes or more if you're using a knot pusher.
Which really hurts us a little bit because we've got to be even faster now getting that potassium out and getting rewarmed.
Well, true, but if you communicate and you guys see that I'm using that, then you know to remind me.
Yeah, except
right,
well,
we
no, we
can't
can't start too early because we don't want the heart to beat.
True, that's true. But you can, once the valve is in, especially on a replacement where you're not as concerned about a significant leak, you don't have to really worry about that. Now, in a repair, I get it. You want to be a little slower, but again, you have the benefit of being on FemFem. Regardless if the rate's slow coming off, you can wait a little bit. Especially if you're learning with this new technique, it does simplify it. You have time. You can these guys can spin it off a lot quicker than you think. I mean, you're hurting yourself a little bit there on that because it doesn't take as long as you would think to dialyze and get this off.
It was the warming that took longer than getting the potassium off for us.
In larger patients, you got to consider that.
Yeah. Which I think surprises
this guy's
a lot
super
of people.
skinny, so it's not that hard.
Right.
So now we're checking the valve. You put your weight, don't forget, now you got CO2 in there, put your weighted drop sucker through the leaflets, make sure you have plenty of slack because they're kind of sticky with the other cannulas and your suckers and you're going in and out. You want to keep that in till the atrium's closed. And I'm testing the valve with, usual method there. You really don't have to, especially this guy who's got pretty good AI. Just let it fill up and test it with a pickup, okay? And I've done mechanical valves. The replacements, obviously, they're even easier this way than it is with an open procedure because you can see the anterior portion of the annulus. So we're trying to get the atrial lifter out. Don't forget your pacing wires. I always forget because you're so you're jazzed about getting finished. The pacing wires, that can be a little challenging putting in. I just always use ventricular wires because that's the way I was trained. You can do atrial and ventricular. Get you a good piece of epicardium to put it in and bring it out to the right upper quadrant of the abdomen or right lower portion of the chest. I usually just use one and a grounding wire because I'm a big believer also, and this is the other reason I wanted to use this technique, was I believe the fewer holes you have in the heart, the less chance you have to bleed. Okay, yeah, so same thing for aortic valves. I don't put a superior pulmonary vein vent in. Dr. Ott dropped one through the root, and you kind of get blind to it. It's kind of like a fire hydrant in your yard. When you buy that house, you're like, man, there's a fire hydrant in my yard, and it's an eyesore. Nobody knows there's a fire hydrant in your yard. And we just recently had a big freeze down here. Nobody notices where the water meter is. I had to go find the water meter for my sister-in-law and turn it off because she had a leak in her house.
Oh, Lord.
Yeah, but you think of all these things that, that you don't, that are kind of like eyesores, but you kind of get neglectful of it. So same thing for me with the aortic root vent. So that's just a little aside. So I don't put a superior pulmonary vein vent in. I do not like it.
But getting back to that pacemaker, making sure you put it on before you fill the heart.
Yes,
once you come off,
it is very painful to put in. And it's not the end of the day if you do. You're there in the operating room. You could float a temporary if you want. Make sure you at least get an atrial because that's easy to put in. Because you're in this particular instance, you're more likely to have bradycardia from kind of a slow atrium than you are to have heart block from hitting the bundle of His on an aortic valve replacement. So if you have an intact bundle, an atrial wire should suffice, so at least have that if you forget. I haven't done that yet, but mainly it's because Stephanie and these guys have reminded me. I think I forget about 50% of the time on the wires.
You never.
Because you're ready to get done.
You never forget anything, sir.
Right, whatever. Not the super important parts, but I've forgotten pacing wires. Anyway, so the heart you can see was filled there, and now we're coming back to the monitor. And we are rewarming, and we've obviously stopped the potassium. The heart's, the LV's decompressed, although the right heart still has some water in it. You can see there's a little bit of air in there, but that's not significant. Now, on this particular one, the LV vent has slipped back once the heart filled up, so you got to put it all the way into the apex. But again, it had sucked out enough of the air to be insignificant. Oh, you got to have single lung ventilation, obviously. Anesthesia has to put in a dual lumen tube. For this, contraindications are, if you get in there and you got dense adhesions, it's your level of comfort on taking those down and looking. But there really are very few contraindications to trying this technique. It's the same ones you would utilize for what I would call a traditional, it's kind of funny saying that now, traditional minimally invasive mitral valve surgery. But this technique simplifies it to where if you have been hesitant to use it or you feel like you have resistance from anesthesia, because it does put a large burden on them, this technique, basically they're sitting back there, in the case of one of our CRNAs, listening to YouTube videos while perfusion's doing all the work. So if you're a perfusionist,
that's how it always is, isn't it?
Drinking coffee and watching the Wall Street Journal. That's the
correct.
anesthesia mantra.
That's right.
Exactly.
Correct. All right, so in our institution we use CRNAs that are very well trained. So if you're hesitant about that, you can get the right CRNA, and in a lot of ways I like them better than the anesthesiologists. No offense to anesthesiologists, but as a surgeon you tend to have a little less of that dynamic of, it's my way, no it's my way. So that's just a little preference of mine. And the timing of this is once you decide to come off and stop the potassium and they're rewarm, it is See the sharp QRS complex? It's not that kind of wide, ischemic, you know, coming off sluggish. I mean, it's pretty snappy. It's because you've not had an ischemic arrest. So this is for a skinny guy, pretty generous incision. It's one of my first ones. I use JP drains. Put one in the pericardial space, just fit it in there, and one posteriorly in the pleural space. You can see your wires coming out. We've decannulated, repaired the arteries, and getting ready to go to the ICU.
Very good. That's excellent. That is great. Did we ever find Dr. Jones?
He says he's ready, but we can't get Skype with him.
Can he just call on the telephone?
He's working on that right now.
No. Okay.
Yes, what does he need to call?
Yeah, he has to call our call-in number. Just have him call our call-in number, and it could just be on the phone, and I think we'd be okay with that. Yeah.
You know,
So-
just my background. I mean, I think I trained at the best place in the world, but I was a great laparoscopic surgeon, at least in my own mind. 20-minute gallbladders, 15-minute gallbladders, heart surgery. I didn't want to do anything like this. I mean, this technique basically, I wouldn't say revolutionized my practice, because I still do a lot of open, complex stuff, but this is a nice adjunct to my practice, and it's only because of the simplification of it. I mean, because the last thing I need is to be running anesthesia, running perfusion, worried about all these different variables, and the number of variables are decreased by at least half, I would say, by using this technique. This is so, I mean, it is truly so simple and so safe. And I think you've even thrown it out there. You're willing to teach anybody how to do this. This isn't proprietary. I mean, this is,
No. I mean, look.
you know, this isn't Joe Basha's technique. I mean, but
I do take a royalty. Anybody that wants to use it, I don't mind.
well, anybody can go on fem bypass and
Yeah.
give high K and then
Yeah,
dialyze it
yeah,
off. All right,
yeah.
but the point is,
potassium off that.
but you know, from especially a community surgeon standpoint like me, or maybe even an older surgeon who's not really wanting to do this, or a younger surgeon just coming out who's by himself, this takes a lot of the burden off of the surgeon. It really does.
Well, man, how many people here on the panel have used port access?
See, I've never used it, so I can't weigh in
You've
on
never
it.
used it. Okay, so you know, it used to be heart port, and then it became port access. And look, I mean, it was agonizing.
It's painful.
I mean, you would sit there at, you know, start the case at 7 o'clock in the morning with the patient in the room, and it was 11 o'clock before they got all these lines in. You know, that's
right.
what you all saw. But you know, the same contraindications for this technique are the same contraindications that actually exist for port access. With the exception, you brought it up, I think, very eloquently, you don't have any ischemic time. There's no having to give cardioplegia. So if you have more than 1+ AI, you're not supposed to use port access. 2+ AI certainly is a contraindication. But I think with this technique and enough sucker
That guy was,
strength,
I
we
think
could
that
do-
guy was
that
pretty
looked like
close
pretty
to
close
2+.
AI.
I think we got misread.
Right, but we just had a big session on TCD and putting the valve, I mean, even if you put a wire around the arch to get down to the left ventricle on a cath, you're knocking off atheroma. There's embolic events occur. So now you're going to put this big endo balloon around the arch and inflate it, and it migrates and it moves. We're not measuring that. You know, I think that is a, you know, is a serious problem. And then what I'd like, if we could, did we get Dr. Jones on the phone? No? Okay. So while we're waiting to get Dr. Jones on the phone to kind of discuss that first case, Stephanie, do you want, I think that might be him right there. Yeah, please. Hey, Dr. Jones.
Hey, Joe, how you doing?
I'm doing great. Hey, Dr. Jones, you're here on our panel. Here is Dr. Mark Mettauer. Stephanie, he's, I think you know Dr. Mettauer from the conference.
Hey, Dr. Jones.
Yeah.
Stephanie Ibus, perfusionist, Tran perfusionist, and of course you know Clint. I think he works with you on a fairly routine basis. And
Hey, Doc.
Dr. Mettauer just gave an excellent overview of with actual surgical video of the hyperkalemia technique for minimally invasive mitral valve surgery. And I was wondering if you would be so kind as to sort of describe that first procedure that we did when we did this technique. So the technique I did originally with Dr. Jones is the first case, and maybe talk about some of the resistance people may have had, but how it ended up essentially, you know, your decision to try it because of the patient's anatomy, having previous surgery, and the lima on the sternum, and just talk about how that first procedure actually went.
Okay, first let me tell you, Joe, I want to congratulate you on your webinar program. Actually, I was watching you guys, waiting to get connected. I'm sitting in front of my computer, and apparently I'm on the Wi-Fi, but for some reason, it's not coming through.
That's okay. Everybody knows how good looking you are, Doc. So and you got a great voice. So we'll just put a picture. I wish I had a picture of Dr. Jones. I'd put a picture of you up if I'd have known would have had a trouble connecting. But you know what, everybody in the audience, go ahead and register for the New Orleans conference today and come visit with and meet Dr. Jones in June. So that's the best way, I think, to handle that. But go ahead, Doc.
Well, let me just start off by saying that this came about because at that time in our program, I was looking for a better way to do minimally invasive mitral valve work, and actually had traveled to several locations to view their procedures, and actually came back a little, I guess, befuddled, because I thought there might be a better way. So when I was presented with this case, the lady who had previously underwent coronary bypass grafting, and all her grafts were open, and she needed a mitral valve procedure, I knew I didn't want to do a reduced sternotomy if at all possible. So putting together that case, and Joe, you were intimately involved in, and putting that idea together, I had seen this done, but it was done with fibrillatory arrest. And that case lasted about an hour. And although the patient did recover, the post-op was difficult. That was a case I viewed at another hospital. So I thought, why have the myocardium using that much ATP when we can arrest the heart and do the procedure and hopefully get a better outcome. So again, putting that idea into practice, we came with the idea, but let's just stop it with high dose potassium and do the procedure. Now, as you remember, there was no literature that we found that had described anything of that nature. So we were sort of like on not fertile ground, I guess you say. But knowing that this could be a better procedure for the patient, we embarked on this, what turns out to be the first case, actually, that we ended up getting printed of hyperkalemic arrest for mitral valve repair or replacement.
So, hey, Roger, do you have that article by any chance that you can throw up there? And Dr. Jones, we did find a picture of you. So, you know, getting back to that port access, you brought up a really good point because this was a redo with all patent grafts. So you got the mammary, And now you're gonna, if you're using port access, you're going to have to deal with that, and you have, because you're on pump, right?
Mm-hmm.
And so that's going to continuously be perfusing. And if you have patent vein grafts in the aorta, you're going to occlude them with the endoballoon. So that's yet, or you don't think so, or
well, it depends on where they are, but
yeah, possibly.
Yeah, so you could basically give retrograde the whole time.
Yes,
or
so you have to
certainly
do
not
the
antegrade,
retrograde.
yeah.
Certainly, exactly. So yeah, so that first case. So so how'd that patient do?
Well, actually, she did extremely well, and we were very pleased with the outcome.
So there's your article.
Oh yeah.
Which led us to having that in our armamentarium when those type of patients presented.
Mm-hmm. So, did you have any fear when we first did it? Were you afraid?
No. I think we have planned it out to the point that if everything ain't going well technically, she would have a good outcome.
Mm-hmm.
Well, it's the same thing I discussed earlier, Dr. Jones. If it's not going to sit up right, then you can be committed to the sternotomy, and you're already on fem bypass, and it actually makes it a little, as you know, a little safer to do a redo sternotomy. I think, in my opinion, we don't always like to do that, but I'm always wired out on a redo anyway for a redo sternotomy for fem bypass.
So let me ask the perfusionists in here. Can you guys discuss the circuit? So you're actually the first. So I got to do the procedure first with you. Now, what did you think when I told you what we were going to do?
Dr. Jones may not have been nervous, but I was a little nervous.
Okay, and Stephanie. So I got to do it first with you as well.
Stephanie's eyes were that big.
I was uncomfortable.
You were uncomfortable,
Yes.
And Min?
I didn't know what I was getting into, but I was ready for it, but it was a little bit
That's
nervous.
what I was saying. Min's my favorite, by the way, in case anybody didn't know that. So talk about the circuit. Stephanie, can you describe the perfusion circuit and how we set that up?
Well, initially, we always have a hemoconcentrator in our circuit anyway, so we had the one, and then we added another one through the roller head where we would usually do the cardioplegia.
Hey, Raj, do we have that diagram? I'm sorry to bother you. Forgive me. Go ahead, Steph.
We've had questions of, do you really need 2 hemoconcentrators? And I would say yes, so that you could get it all off in a good fast amount of time. Then I also used one of our other pump heads to Y in our Duosol for continuous infusion.
Can you talk about Duosol, what Duosol is?
Yeah, so these are a couple of the things that would make maybe if you're starting at a small community hospital, you might be uncomfortable with the things we're telling you to get. At St. Luke's, they do continuous renal replacement therapy, so they already have the Biberon. But you have to have 0 potassium bicarbonate Biberon so that you can continuously infuse. We're basically Z-buffing. And people have asked also, why can't you just drop a liter, take it off, drop a liter? But if we're replacing about 10 to 15 liters of fluid, it works a lot better just to have a continuous infusion. So what I noticed, the speed basically ends up being around, we're taking off about 250 mLs every minute, and that's what we're replacing with. So in 30 minutes, that's 7 liters, 7,500 mLs. So you can see in 30 minutes you can get off quite a bit with the 2 hemoconcentrators.
Now he talked about that one of those patients where we gave a massive amount.
That was very
and that was
unusual.
an outlier.
It was an outlier.
But how much of replacement fluid or Z-buff, CVVH did you do on that patient?
I would say we were probably around 20 liters.
20 liters, and we still had a little bit of a problem post-operatively with with a little bit of rebound hyperkalemia, if I remember.
We have seen that a little bit in our patients. You're going to
It's
get
the
a
big
little
patients.
rebound. Yes.
It's the larger patients. So.
But we've been actually just giving Lasix before we leave the room, and I think that's helped a lot.
So, yeah, that's a good idea. And of course, you could do, glucose and a little
We've
bit
done
of
that.
insulin.
We've done that as well. And you just have to remind the ICU, because they're being educated on this as well, that feel comfortable in ordering more labs, eye stats, follow your potassium, and believe your potassiums. And it's not going to sneak up on you, but it's unless you draw labs for 12 hours. But yeah, it's the larger patients we've been had not a trouble with that, but we've had a couple of that outlier, another large lady we did. But it's part of the critical care management. Our pulmonary critical care physicians and nurses are now more comfortable with it.
Well, Clint, so you've probably done the most cases using this technique of anybody at this table. So what's your what kind of wisdom can you impart to our colleagues out there in web world about this technique?
Well, I think our circuit and our setup is basically pretty similar to what you described. I think the 2 hemoconcentrator technique is definitely the way to go. I think the first couple of cases that you and I did together, we didn't cool very far. We weren't using esmolol, and I think once we started doing that, I mean, we saw the amount of potassium that we had to give these patients, go down, dramatically. I mean, I think when we first started, we were starting with a bolus of 240, 260 milliequivalents, and I think now in our protocol, what we use back home is we start out with 180 milliequivalents and see where we're at from there. If we need to give more, we give more. If we, and I'd say more times than not, we don't. But to go back on that, us cooling down to 30 degrees, 28 degrees, 25 degrees, whatever we need to do, and anesthesia given the esmolol bolus and starting an esmolol drip once we go on pump has helped out tremendously.
Min, what's your thoughts? Now you've only done one case.
I've only done one, right? but I've watched about 4 cases.
About 4 cases. What are your thoughts? What could you tell our colleagues out there about who want to try this technique? Let me tell you this before to kind of give you a sort of a background. Stephanie and I, we published that case online on ViewMedi, and anybody out there that is looking for a great resource for educational videos is viewmedi.com. They do a fantastic job, and there's a lot of material out there for learning about stuff that hell I'd never heard of, and it's really, really interesting. But we have gotten about 6 calls from people, 3 of them who said they really wanted to do this, but then they ultimately didn't. And Dr. Jones, maybe you and Dr. Mettauer could weigh in on this too, but why is that? Why do they say they want to do it, but they seem to have this level of fear and they just won't do it? Because it seems like a no-brainer to me, a much better technique.
I think in the perfusion community, just in surgery, doing a case, there's always the fear of, safety issues and the unknown and what people aren't really familiar with. But, I think if, you have the right people setting things up and kind of getting you on track on how to do the cases, what protocols to do, how to approach it from anesthesia, surgical standpoint, and perfusion standpoint, and everything's laid out. I think it's a safe method to arrest the heart with no ischemia, and as long as you get the hemoconcentrators in to get the potassium off adequately, when the patient comes off, I think it could be a great case, especially for the because you want to do minimally invasive procedure and not having to use the endoplant.
Yeah.
For me, it was. Go ahead, Dr. Jones. Sorry.
No, go, Mark. Go ahead.
Well, for me, I don't know. I think I was particularly tired when Joe approached me with it, so I was like, sure, let's do it. But I'm not putting any brain ATP in doing this. I'm going to do the mitral, and you do everything else. And anesthesia, oh my gosh, they were like, hesitant. Fortunately for me, I didn't have the perfusion pushing back because it was Joe. So I didn't have to fight that battle, but we got one of our more aggressive anesthesiologists involved who will pretty much do any case and doesn't care. And so, because he put all the burden on perfusion as well. And for me, that's where I left it. And again, your fem bypass, the wheels aren't going to fall off the cart. Even if you give a whole bunch, worst case scenario, you're going to let it wear off. Give a bunch of Lasix, whatever. So, but the learning curve, like I said before, is, would you agree it's steep?
Absolutely.
I to be honest with you, I don't want to learn how to do it, but it doesn't seem to me like I would have to do that many cases, or at least watching to be able to instruct somebody how to do it. I mean, Stephanie did one case, was like, that was, yeah, you can do it.
This was easy.
I mean, this was easy.
Yeah.
I mean, it's
but
not.
Doesn't it shorten your operation too, Dr. Jones? Doesn't it make the operation itself shorter?
Well, it did for us. And I think that you have to have the perfect storm. And what I mean by that is, when I said I wasn't afraid when I first did this case, that wasn't the first time I had used that approach to do a mitral valve. That had been in my armamentarium for a long time.
You're talking about the right anterior thoracotomy.
Exactly. Right. I mean, the mitral valve, minimally invasive, aortic valve, minimally invasive. So it wasn't my first time doing it. It was the first time we were going to use this particular protocol to arrest the heart. So, I mean, I don't think this should be someone's first out the gate time of doing a minimally invasive mitral valve. They should try it.
Well.
Also, it was great that Joe was there, and actually we had talked to Joe for a while. As far as anesthesia was concerned, they came along without any difficulty. So it was a perfect start.
Well, it was my first.
So that was your first.
That was a first minute.
Yeah. Anterior approach.
I'd seen George Rule do one through a big, huge right thoracotomy, but it was it was my first.
But you know, if the patient doesn't get a sternotomy, that is better for them. I mean, in terms of their recovery and everything else. I mean, I'd rather have it done, especially women.
Yeah.
You know, I mean, it's much.
There's a lot of benefits. I mean, you know, a thoracotomy is not without problems too. I mean, you can get chronic post-thoracotomy syndrome, but yeah, I agree. I mean, it's if it's an isolated mitral valve, I don't even care about that, to be honest with you. I don't care if, you know, about if it's a sternotomy or thoracotomy. For me, it's exposure on this. I mean, it's so much easier. And I think anybody that does minimally invasive mitral valves, robotic mitrals, whatever, knows that it's easier. I mean, I don't see why this wouldn't, you know, at a robotic center that does mitrals, I don't know why that.
Yeah, I don't
know. This is, in my opinion, the easier way to do it, especially if you're and most of those are in residency training programs. I mean, FemFem, High K.
And there's no rush.
And no rush.
You're not
the
stressed.
resident can do it. You know, you can do or get through part of it or whatever. Yeah.
So, Clint, Stephanie, one of the things that I've noticed is that when we come off pump with these patients, and Dr. Jones, Dr. Mettauer as well, but I noticed that their hearts almost appear, even if they were a little depressed to start with, hyperdynamic. What do you attribute that to?
I think it's 100% FO too, to be honest with you. I mean,
good perfusion.
I think it's temporary. I think it's temporary.
It is. They tend to go back. Yeah. But how much of the high volume ultrafiltration do you think contributes to the removal of inflammatory?
And the heart's not distended either.
That's true.
It's not swollen.
No walls. No.
You don't have this. Yeah, you can close the pericardium if you want. I usually put just a couple stitches, but it's not like after doing an open where you get that reperfusion and swelling. You don't have the swelling.
Yeah.
Well, I mean, I think it's all of that. I do, and I think 100% as well. When you're doing high volume CRT, in particular CVVH on these cases, I mean, you're removing these inflammatory mediators, systemic
you're not getting a
inflammatory
surge type response that's
right
out of control.
Yeah, I think it's
absolutely
it's a big impact, huge.
I do want to touch on the.
Hey, Joe, let me
Dr. Jones, go ahead.
Something that's probably obvious. There's no better perfusion aid for the myocardium than blood.
Yeah, that's true. That's true. That's the best cardioplegia in the world with potassium in it.
The question I've been getting a lot is, what does all that potassium do to the rest of the body? Are we causing any harm? And I'll tell you, we haven't seen any issues. They're awake, extubated the next day, talking. Have you seen any?
No, the physiology of the human body is if you have systemic potassium is to get rid of it, whether it's pee it off, drive it into the cells. I mean, the ionic gradients are such that it's going to happen. You just, I think unless you know, once you get most of it off with what you guys do, the human body takes care of the rest. It's not. It's you're resetting that, and from that mechanism, the potassium, sodium, ATP.
Sodium pump and all
yeah,
that.
all of
stuff.
that.
Right.
Sodium, potassium.
Well,
yeah.
you know, interestingly enough, 400 of potassium is barely 10% of the total body load of potassium. So it's really not not as much as you think it is. It's just extracellular. It stops the heart. Now, 2 caveats to that. Don't give it fast.
That's right.
Because if you do, we've seen that before. You'll see a big spike in your blood pressure. You'll see that reaction occur. But you know, in talking to every physiologist and pharmacologist and intensive care doc that I could find, nephrologist, everybody, there is no morbidity associated with giving someone 400 potassium except cardiac arrest, diastolic arrest, which is what we're trying to achieve, unless you're in Huntsville, and then, you know, the consequences. So you need to be on bypass to do this. But going back to that solution, the pediatric folks are very, very familiar with this. So we've all, as perfusionists, we've Z-buffed in the past using normal saline. It's acetate-based, not bicarb-based, so you get the pH adjustment, but you dilute your bicarb as you constantly are doing, removing fluid and replacing it with saline. This solution is normal physiologic bicarb-based, but they just take the potassium out. You get multiple formulas with calcium, without calcium, with potassium, 0 potassium, 2 potassium, 3 potassium, 4 potassium, whatever it is you want. So we use 0 potassium, but we can do this enormous volume of hemofiltration, Z-buffing in essence, for, you know, people who are watching this familiar term, and have the bicarb the acid-base balance just stays perfect.
I would not try to do this with just normal saline and bicarb.
I wouldn't either. It'd be a horrible idea.
If you're thinking about it, don't.
Horrible idea. So, so with all of that said, Dr. Jones, any final thoughts on what we're going to do? Now, I don't know if you have the time, but if you could just hang on for a little bit. I think we want to go to a quick commercial break, and then that gives people time to call in because they may have some really good questions about this. And I think we'll put the call-in number. So if you want to call in and ask any questions of the panel that's here, and also Dr. Jones, who's remote over in Louisiana, Roger's putting the number up right now. Go ahead and call in, and the phone lines are open. And Dr. Jones, do you have a few minutes to hang around?
Sure.
That'd be great. Okay, so we're going to go to a quick commercial break. You'll still be on the line with, actually, how are we going to do that, Roger? How can he be on the line?
He can stay on the line through it all.
He can stay on the line through it all? Okay, good. So yeah, if you'll just stay on the line, you'll still be live with us, but we're going to go ahead to commercial break, and then when we come back, some people will be calling in with some questions.
Okay.
So we'll see you all back, and just watch the commercials, okay? Remember, we got to keep the lights on, and we monitor who's watching. So if you leave and try to go to the bathroom right now, I'll see you left your computer, so hurry back.
Cannulae, less jet, more natural dispersion. Neurologic complications during on-pump cardiovascular surgery are often induced by mobilization of atherosclerotic plaques, linked to enhanced wall shear stress of the arterial cannula jet flow. OptiFlow arterial cannula features a unique basket tip with large openings that allow a more physiological flow. OptiFlow arterial cannula has shown to reduce the pressure on the inlet jet system on the aorta, thus mitigating arterial embolization of atherosclerotic plaques. After purse strings have been positioned and the incision in the ascending aorta has been made, OptiFlow arterial cannula is inserted, then turned towards the aortic arch to allow a centralized flow. OptiFlow provides optimal dispersion flow with no jetting compared to a standard tip cannula. The dispersion flow of OptiFlow reduces the wall shear stress values by approximately 50% compared to a standard cannula, with the potential of reducing ECC complications such as strokes, endothelial damage, and hemolysis. OptiFlow arterial cannulae are available with straight and bent tips in 21 and 24 French sizes for all patient needs. The unique basket tip design reduces the pressure gradient along the cannula, thus improving blood flow dynamics. Tubing is DEHP-free for a clear and more transparent look and feel, available with and without wire reinforcement.
Okay, welcome back, everybody, to the show. I think our phone line, Dr. Jones, you still with us?
I'm here.
Okay, are we going to get any, so Roger, people can call in?
Well, we're going to have to merge the call.
Okay, so how would we know if they were calling? You'd just see a...
Yeah, I just see it on the phone.
Mm-hmm.
Give me 1 second.
Is there...
Nobody's called so
Oh, nobody's called so far? Oh, come on. We don't have any calls? Everybody left?
Oh, they're listening.
Yeah, they're listening. No question. So I guess what we could talk about is, I think Clint and Min wanted to talk about how the Saints got robbed.
100%.
Oh, man.
And so that was a... Dr. Jones, did you cry?
Excuse me?
Did you cry
When?
when the Saints lost?
Oh, well, I wasn't exactly crying.
A true Saints fan wouldn't cry.
Yeah, that's right.
No, I wasn't crying.
Yeah, the bad part about it is one of our perfusionists that we work with is he's actually from Pittsburgh, so he was a Steelers fan. And I was about that close that morning to calling him and messing with him about Pittsburgh losing. I said, well, I better wait a little bit and see what happens with the New Orleans game.
Right.
I'm glad I didn't do it.
I had the same feeling, Kurt.
Well, if we don't have any calls, you know, how about we just go around the table in case unless somebody does call in, and we'll you'll let me know, and we'll just start with the left side, or actually let's start with the speaker first, Dr. Jones. Any final thoughts regarding what we've been discussing today? And we're just going to kind of go around the table here and move forward.
Well, like I said earlier, I think this is something you want to have in your armamentarium for certain cases. And it does benefit the patient, and it's something that you can easily adapt.
Hey, Doc,
Yeah.
I'm sorry to interrupt you. We did get a call for a question, so we're going to interrupt you. Okay, and we're going to merge the calls. Hold on. So,
We're back again.
okay, hello? You have a question
Hi
for
there.
us?
Oh, I sure do. Stephanie, can you talk a little bit about
Do you mind?
how the potassium is administered?
Yeah, I'm so sorry. Do you mind telling us who you are and where you're from?
Sure. This is Patrick calling again from New Orleans.
Oh, hey,
I'm sorry,
Patrick.
from New Orleans, from Houston.
Okay, you actually work with us, but I didn't recognize your voice. Okay, what's your question?
I wanted to ask Stephanie about how the potassium is administered. You mentioned you don't give it all at once, and I wanted to hear a little bit more about that.
Sure. So we initially start out, I have 180 milliequivalents drawn up of potassium in a syringe, and I just give it slowly over a few minutes, and you'll just see the heart gradually start to stop. I say more times than not, we do add another, I'd say 40 to 80 over time, but only to if we need it. If Dr. Mettauer is complaining that the heart's still beating and he needs it a little more still, I'll just keep giving a little bit at a time until we get to where we need to be. Would you say that's about right, Clay? Over like a few minutes?
We do the same. Like I said, we start out with 180 milliequivalents as well. More likely than not, we do have to add a little bit throughout the procedure. Every once in a while, you'll get a little beat here or there, and you'll hear either Dr. Jones or Dr. DeWitt, who Dr. Mettauer was talking about earlier, who he trained with. Of course, they'll let you know as soon as you get a beat.
The heart's beating, oh my God.
Yeah, it's not about, it's just, it changes the dynamic. I mean, it really changes it quite a bit.
That's what it is. I think the biggest key is a gradual delivery. And like I said, what helped us out with the cases that we've done quite a few here lately, is when we kind of put our heads together and kind of figured out, cooling this patient a little bit is going to, help us out. Anesthesia, starting some esmolol, putting an esmolol drip on. Like I said, it significantly reduced the amount of potassium that we have to give during these cases. And I mean, I'm assuming you guys probably do the same over there.
So we usually start the esmolol drip when we go on bypass,
Correct.
and then when we start taking the potassium off, we shut it off.
We do the exact same.
Okay.
And I don't want to, I think that, I don't want a perfusionist out there to be freaked out about, cases like this. I mean, honestly, yes, it is helpful to see one, and it's, kind of freaks you out the first time you hear about what you're doing. But, for us, and I know, of course I had Joe there to help me learn how to do it, but now it's like any other case. I mean, it really is. I mean, the setup is not extremely difficult. I mean, you take your cardioplegia setup out and replace it with the setup to do the CVVH, and I mean, there's not much to it. So I mean, I don't want to freak everybody out and think that this is something crazy.
It's really
that
pretty
nobody
simple.
can do. It is.
Yeah, we had put the diagram up. That diagram that your brother drew that for us, right?
He did.
And he's a CAD designer, a CAD drawer, or whatever. But let me just ask everybody here: Dr. Jones, Dr. Mettauer, Stephanie, Min, Clint, of course, myself as well. If anybody out there that's watching this wants to try that, whether you want to talk surgeon to surgeon or perfusionist to perfusionist or whatever the case may be, you're welcome to reach out to any of us. We're happy to discuss the case with you and help you get through the first one if that's what you'd like to do.
One thing I switched to, I did have the second hemoconcentrator going through a roller head, and that just helped ensure that we didn't get any backflow or air into the system. But we had a case where we needed an extra vent, so I had a pump for our dialysate, and then I had to pump for the hemoconcentrator, and I had to pull my hemoconcentrator out to vent. And what I found is that once I added a one-way valve into the second hemoconcentrator, so I wasn't worried about backflow in that anymore, it really simplified it for me because I'm not running that as an extra pump and having to watch it. It just
Continuous.
It just went continuous. And,
Now, see, I don't like that. I
Okay.
don't like it because when you have that line going into the top of the reservoir, and we use vacuum assist venous return, that's a negative pressure. And so I like to use the roller pump because I can generate a much higher pressure in the blood phase of the fibers, and it helps to push the ultrafiltrate out a lot faster, and I can ultrafiltrate a lot more volume in a shorter period of time. So that's why I like to use the roller pump.
With the positive
Not
pressure,
necessarily
right.
for the flow, I do it for the pressure, for that positive,
positive
pressure,
pressure.
in the inside of the little pipettes, the little fibers.
I haven't seen that it slows down any, but maybe, you know.
Yeah, I mean, maybe I just need to
Because
try it.
if I still ran my dialysate at the same rate. So
Did?
I don't.
But you're hooked up to a Neptune though,
Yes.
right? And
yes.
that's massive negative
Yes.
pressure. So, do you recommend you use a Neptune, or you use suction, or do you let it just flow through just the pressure gradient
Oh, I think
into
it's
atmospheric pressure? Or do you hook it up to a suction?
I hook it up to
You
suction
need
too.
suction
Yeah.
for
Yeah.
this.
Yeah, I agree with that.
The gravity drainage is just going to take way too long, and it's going to extend the procedure out, and it's going to get these guys on our back.
They
and
get
bad shape.
anxious. They get anxious.
They say they're patient, but they're ready to come off when that valve's in.
I know. Well, but that's directly contradictory to what you just said a minute ago. There's no worry.
There's no
if it just
rush.
takes a little longer,
No, you're-
that's
but I'm
okay.
telling you.
That's fine.
I'm patient when it comes to what I'm doing.
Yeah,
Right,
exactly.
exactly.
When you're
And then when
ready
that
to
valve
come
is
off,
done, the
we
heart's
need to be
closed,
ready to come
you're
off.
ready to
And
come off.
chances like that too, Dr. DeWitt. Another call? Okay,
Thanks,
Patrick, thank
Patrick.
you. Another call? Oh, no. Hello?
Hello?
Hey, who's this?
Is that Jeff?
This is Joe.
Oh, this is Gopi Kalur. I'm a perfusionist.
Hey, Gopi, how are you? Nice to talk to you. What you
Yeah.
got? What you got, Gop?
I just got a question about they didn't touch the basis of the perfusionist point. No. Can they use?
I'm sorry, Gopi. Could you say that again? I didn't understand your question.
I said, what cannulation technique do they use?
Cannulation.
Yeah.
Oh yeah, film. I mean, gotta be. I mean, that's. I don't know.
Well, you could do.
Want to do any other way
If you
than
got
that,
horrible
but-
peripheral vascular disease, you could do femoral venous and an axillary.
Yeah.
I mean, I haven't done that, but having
I
peripheral.
just wanted to know what kind of cannulas did you use?
Oh, you
That
can use
is
the
most
Edwards. You
crucial
can use
part.
Gopi. You could use the Edwards.
Medtronic.
Or the Medtronic, or the Soren, I think, or Livanova, whatever they're called now, has their own version of Aztec cannulas, I think, is what they're selling. The and I mean, any standard femoral cannula like you would use if you had a redo and you just wanted to cannulate and go on pump, or you were doing VA ECMO.
Right, a percutaneous cannula set, but through an open technique.
Right.
I mean,
Yeah.
so you're not sewing it into the artery or, using umbilical tapes or silastic loops or whatever. Basically, I mean, sometimes you have to, but basically, you want to get enough of the cannula in there. When I was at Texas Heart, we used the old cheap beveled aortic cannulas, and barely there's like a centimeter tip in there. And but the Edwards percutaneous kits, but just do but just do an open technique that way, because the surgeon's gonna have to fix it afterwards. But the options would be axillary film or fem.
Right.
Hey, Dr. Jones, you still with us?
Yes.
Hey, can you talk about placement of the venous cannula? Because if you've got crummy drainage, the procedure is horrible. Placement and drainage is critical. So what is your placement? Where do you choose? Where do you attempt to place the tip of that VFem cannula to get the best drainage?
Yeah, I want that area in the superior indicator. Because then I know that I have the vascular opening in the body of the right atrium. Therefore, I think I get better venous drainage with that position.
So where do you put it again? I didn't hear you.
Well, I like the tip to be in the superior indicator.
Okay, so you put the tip. So you go all the way up through the atrium into the superior vena cava with it.
With the tip, yes.
And you can actually feel that through. You can feel that, right, through your thoracotomy.
Generally, I mean, unless you got,
Yeah.
unless you're 6'5" and 300 pounds, and then anesthesia helps because sometimes that tip does go into the atrium, and then you have drainage problems.
At least about an inch inside the SVC.
Correct. Yeah.
Did you take it? Yeah.
The atrial lifter will sometimes change that, so you may have to modify that and place some in a little bit further when you lift, because it may pull it out of the SVC. But it's pretty easy to manipulate from the groin and the chest at the same time.
Now we had a case one time. I think it was you I was doing the case with, and the drainage was horrible. I don't know if you remember that or not. And I think they were just yanking up on that lifter, and it was, you know, just a real difficult anatomy, and they really had to yank up on it. And that cannula wasn't in the superior vena cava.
It flips out and goes into the atrium.
Yeah, and we stuck that cannula in the right IJ. You remember that?
Right. Oh, yeah. So
we
you
put an opti in the right IJ and wired them together, and it was beautiful.
Right. That's another option, is you can dual cannulate that way, kind of like you know, traditional mitral surgery, except you're doing it through the IJ and the femoral veins.
And you just use a little small arterial cannula, and with the vacuum assist, it just worked. It really worked well. I mean, it got us out of the heart decompress, everything. It just calmed everything right back down again. Yeah, you have bad drainage and the heart's stuffed, and you can't.
Well, and that's
see.
the other benefit of not having a
painful.
retrograde cardioplegic catheter in. You got that access, the neck's open, ready to be used. In case that happens, you can really stick a right IJ catheter in real quick.
Did we have another caller? No. Same. Did we have anybody else online?
Yep. I'm still there.
Okay, Gopi. All right. Well, I hope that answered your question. Dr. Jones, you're still there?
I'm here.
All right. Well, I think we need to wrap this up. I think are we on time here? 11, guys? Or a little early?
11:20.
Oh, we are a little
I think
early.
one more thing, just from a perfusion standpoint. I mean, if you
No,
know.
I got one more question.
Okay, Gopi, go ahead.
First of all, good morning to all the panel. And
Morning.
Hello, Gopi.
yeah, have you guys tried ever using Del Nido cardioplegia?
I mean, you know, for this type of procedure, or are you saying just in general?
This type of procedure.
Well, no, because we have no need to arrest. We have no need to give cardioplegia because the heart is being continuously perfused with oxygenated blood. So it wouldn't make any sense. We don't ever touch the aorta.
We're trying to prevent having to cross clamp at all.
Right. No ischemic time at all. So I mean, I think Del Nido on its own merit is probably a good solution,
Substitute,
you know,
yeah.
but that would only be applicable if we were planning on cross-clamping the aorta. Because, you know, I mean, you can do your technique. You can use the Chitwood clamp, you know, that articulating one, and snake it in there. You know, you make another incision and you put it in there, but those things slip. I think you've done a lot of cases with the Chitwood clamp, haven't you? And it slips off. You've got the heart stop. Now it's beating again, and it's pretty frustrating. So, you know, I mean, your question's a good question, but I don't think it's applicable in this scenario. Okay, well.
I guess I have one last thing to add.
Yes.
And then Clint can. We have really an astounding heart team at St. Luke's, I would say. And one thing that helped me a lot was having good circulators too.
Oh, yeah.
I mean, we get a ton of calls from the lab, from the pharmacy. You want how much potassium? You know, you know your K is this.
It's a battle. That's a battle.
Yes, and having good people around you helping me to get the solutions I need, the potassium I need, getting things to the lab quickly. I think that really helped alleviate a lot of the problems that if you are trying to do this as a perfusionist by yourself and the surgeon's like, okay, you take care of it, and no one's helping you in the room, then I do think like you have to be really prepared and planned out and talk to each department and be ready.
Well, let me, you brought up that's a very good point, and I'll add something to this. What we use to monitor labs, okay? We really need the Siemens Rapid Point in at St. Luke's. No, I'm being serious about this. We use the iStat. The iStat will only read a potassium to 8. All it says is greater than 8.
Right.
We don't know if it's 8.1 or it's 15. So it's hard for us to kind of assess. And of course, I don't want to get into the minutia of, the simplicity of just, what do you think of that Siemens machine? What's your view?
Nobody's paying me to say anything, by the way. So I love it. I mean, it made ours, the process, a lot simpler. I mean, it gives you the result right there in front of you. You're not having to wait. I mean, you're not guessing at, like you said, where you're at. I mean, you have it basically right there. I mean, if you're at 13, it's going to tell you you're at 13. If you're at 12, it's going to tell you you're at 12.
And you have confidence in the values.
100%.
Okay, and
so have you been in the range of around 11 to 13 most cases, 12 to
now,
13?
yes. When we first started, we had got up to
18,
17, 18, and
again, it doesn't. My point is that it's crazy, but it's no different than 12.
It's not.
It's gonna come off.
Think about
This
it.
is true.
It
This
just
is
takes
true.
longer.
This is true.
It-
Yeah, but it just
as
takes
long as
longer
you
to
have
get
the
it out.
solution to
It
get
sounds
it
like
off.
pure insanity, but it's not. It's just it's
Yeah.
it's
As long as
really
you got the solution and a good perfusionist to
Yeah,
take
just
it
don't
off.
run out of
not
the
a lot.
solution.
A lot of
and
new
you'll be in
stuff
trouble.
out there for heart surgery, but I think this is pretty innovative.
Well, I think unless anybody has anything else, we've had a great session. We're going to go ahead and, we have a studio audience. Nate, do you have any questions? I didn't even address the studio. Nate's shaking his head no. Absolutely not. He's retreating now out of the door. He's running
He
down
hasn't
the
said
hall.
a word.
Has not said a word, and that is highly unusual because
Nate,
Nate
so
is
unusual.
Do you
the
feel comfortable doing the next one after this
yes,
talk?
Nate.
yes.
Yeah. You're
Wow.
doing it.
Oh, he's doing the next one. He's doing it. You're going to have to, Nate. I'm sorry. It's just part of the program. But we've had a great time, and I can't thank all of you enough for participating in our first webinar of our webinar series. Don't forget our website, perfweb.us. Don't forget the conference, theneworleansconference.com. So on behalf of myself and this illustrious panel that I feel so privileged, and Dr. Jones on the phone from Louisiana, beautiful state. Crawfish season's here, but I'm worried because it got really cold.
Yeah, they're gonna be small.
They're gonna be small. The Saints are out of the playoffs and the Super Bowl chances, but that's okay. But I hope to see you again at our next one. I think it's scheduled for February 7th, but you can go online and see that. And we're going to try to keep these topics fresh and new and different. So if you have any ideas, email me. You want to be part of this and do it remotely through Skype or through the telephone like Dr. Jones did, let us know. We're happy. We're looking for people that want to be involved and part of the education process and part of the overall goal, which is to help improve the outcomes for our patients and to share educational information. Information was meant to be shared, not just held to yourself to make yourself look good. It's supposed to be about a greater calling. So let's all keep that in mind. And once again, thank you all very much.
Hey, Joe.
Yes, sir.
I was going to say one thing.
Go ahead.
Don't forget, this is New Orleans' 300th birthday.
That's right.
So the New Orleans conference will be here, and things are going to be happening in New Orleans. So it's a good time for people to sign up right now to attend.
That's right.
Yeah, they're not gonna be in hotel rooms.
So no, we've got them booked.
Well, that's what I'm saying.
We have a block.
You better get the
If you wanna
block,
come,
right?
you better
Yeah.
book.
So, Dr. Jones, do we need to add a day to the block for recovery?
Probably.
All right. Thanks, Doc. You take care of yourself. Great talking to you, and thank you so much for participating.
Thank you, Joe.
Thank you all very much again out in Web World. Have a good day. Enjoy your Saturday.
How about